A clean laptop? It's not your trial laptop, is what I'm asking.
Yes, but we would open it to just the medical records portion. It doesn't have other things on it, but I would trust that the witness would not go swimming in the laptop.
That was just an anticipatory question.
Yeah.
Ms. Menashe.
So it's a laptop that belongs to the state of Ohio?
Well, that's not the issue. Is it the one they're using for trial? And is there other documents on there or not? Or is it a clean one with just the medical records?
Well, there was going to be a series of questions because I know how the court feels about foundation. But first, it's a state of Ohio laptop
Yes, it is.
that has your whole trial file on it?
It has a trial file. He wouldn't know how to get into that, but yes. But if the court would permit that to happen, those medical records to be available, we could load them all onto a clean laptop, have it over here this afternoon, and use it for all the experts coming up. And put nothing but the medical records on the laptop. I'm sure we could achieve that.
And, Your Honor, just logistically, how does that work? It's like, would it refresh your recollection, and then he reviews something that I don't know that what he's reviewing? I don't know if it actually is refreshing, because it might be a different document.
Right.
And how do we get a witness to search through direct examination that is supposed to be non-leading?
Well, it would be transitional for most of that, but, I understand your point, but it's the same questions going across. My problem is it's not been specifically set up for this sole purpose. And we can always hook it in to the system, I think.
I'm just trying to save time, Your Honor, because, one of us can clearly go to, search a word, come up with pain scores or whatever the issue is, and then, publish it. But it would just be, I think, a lot faster if the expert themselves, who are used to electronic medical records, could do that for us. I see it as a time saver. That's all. I'm not trying to...
Well, for right now, let's go with what we got. I won't consider it until I know it's a clean machine.
Yes.
With nothing else on it, and it's just the medical charts.
Okay, great. I think we can do that.
And then we can deal with the issue at that time.
And we'll make it available for defense experts also.
Okay.
Okay.
Let's bring him, David.
For the record, I object to this. I spent 30 hours this week in pulling records, so it's possible. I know, because it's like, so I just don't think it's best practice. This is a murder case. I think that we should be able to see exactly which document we're talking about, and I'm not really sure how it saves time. I also don't think it's an appropriate visual for the jurors to now be seeing someone that the state has hired to be able to manipulate their own laptop. I think that optically that's not appropriate, and we will not, our experts will not be doing that. So those are my concerns, and I object to the practice.
It is out of the ordinary.
I understand, Your Honor.
We'll just do it the long way. Don't even go get to the computer. Sorry.
So, does the court understand there's no pages on these dividers?
Okay. You guys bring the exhibits in here.
I'm sorry, Your Honor?
You guys bring the exhibits in here, okay? I'm not responsible for their creation. I just judge them, okay? So, I'm sorry they're not paginated, but, just show them the blurb that you want to show them.
Okay, thank you, Your Honor.
Okay?
Alrighty.
Objection will be sustained then. David's getting them. I'm going to swear you back in when the jury's present. Okay, just relax.
Well,
a sheet into the envelope.
Yeah, I know.
And then it'll show up on the screen without having to push the jury first. I don't want to do it that way.
I'm old, I'm slow.
Well, you could have,
I'm not taking that.
yeah, but credit Taylor could do it.
All rise. So who hurt themselves? Okay. Someone strained their leg. They may put their foot up there on the cross beam right there.
We pushed them.
Okay, whatever. So he puts his foot up because he has to elevate it. Don't take offense, folks. We're trying to make it work. You all be seated. Doctor, please raise your right hand. Do you solemnly swear to tell the truth, the whole truth, and nothing but the truth, so help you God?
Yes, sir, I did.
I'm a little ahead of myself. Turn around there. Ms. Grubb, why don't you call your witness?
Thank you, Your Honor. The state of Ohio calls Dr. John Schweiger.
Okay. Now, Doc, go ahead and have a seat. Get comfortable. You've got a mic there in front of you. Okay, for the record, I need you to state your name and spell it for us, please.
Certainly. My first name is John, John, Walther, Walther, Schweiger, Schweiger, MD.
You guys hearing him okay? Now, a little more volume?
I heard it, just spell it again.
Spell it again.
Yes, obviously John, John, Walter with an H, so Walther, and then my last name Schweiger, Schweiger.
Now, you all hearing him okay? Okay. Ms. Grove.
Thank you, Your Honor. Dr. Schweiger, what is your professional address?
My professional address is 1 Tampa General Circle, Suite A, 327, Tampa, Florida, 33606, Department of Anesthesiology and Critical Care Medicine.
Thank you. Please share a little bit about your post-high school education.
Certainly. So after I graduated high school, I attended Wesleyan University in Middletown, Connecticut, where I studied religion and philosophy, getting a Bachelor of Arts degree. During that time, I also took all the pre-medical requirements, and in my senior year, I applied to medical school. I was accepted at Rutgers Medical School in New Jersey, which was my home state, also known as Robert Wood Johnson Medical School. I attended there and graduated with a medical degree, so an MD degree. In my last year, I matched in internal medicine at Cooper Hospital, University of Medical Center in Camden, New Jersey, where I did my internship. I had also matched in anesthesiology at Temple University Hospital, which is located in North Philadelphia. I served from July 1990 through June 1993. The senior year, I was voted chief resident in the Department of Anesthesia, overseeing the educational process for the junior residents. And then I was accepted to a critical care fellowship at Temple from July of 93 through June of 94. That was co-sponsored by the Department of Anesthesiology and Cardiothoracic Surgery. And after I finished the fellowship, then I took my first job assignment.
Thank you. What type of medicine do you practice?
So I'm primarily a hospital-bound physician, meaning that I practice at Tampa General Hospital most of the time, with a little practice at surgery centers and some of the smaller hospitals. I am primarily a critical care physician, also known as an intensivist, meaning that I staff the various ICUs. And then the other part of my practice is as an anesthesiologist, taking care of patients in the operating room and throughout the hospital. And in both of those arenas, I practice pain medicine, which is the delivery of medications to reduce, alleviate, or remove pain from patients.
Thank you. Are you board certified?
Yes, I was board certified, passing all my tests on the first attempt. Initially, I was board certified in anesthesia April of 1994. The following year, I was invited to take the critical care boards, and I passed those on the first attempt. And then that would have been 95. And then in 1996, I passed the the American Academy of Pain Medicine boards in acute and chronic pain management on the first attempt.
Thank you. And do you maintain those board certifications to date?
Yes, I'm still board certified in all three areas of medicine.
Thank you. What percentage of your time do you spend in the actual clinical practice of medicine?
So I would say that I spend about 95% of my work week at the hospital clinically practicing medicine, where I'm seeing patients either in the operating room or in the intensive care unit. And then the other 5% is in administrative, managing the Department of Anesthesia and critical care, some professional guidance for medical students, residents, and fellows, and then a very small amount on research.
In the past, have you been an instructor at a medical school?
Yes, in my fellowship year, I was an instructor at Temple in the Department of Anesthesia and Critical Care. And then I was full-time faculty at the University of South Florida College of Medicine, which is located in Tampa, Florida. They recruited me from Temple in '94. And then since I left the full-time employment of the university, I've remained as a clinical professor, having been promoted to full professor in 2016 at the University of South Florida College of Medicine.
What positions of trust or supervision do you currently hold at the hospital or in your medical practice?
Yes, so starting in 1999, I was appointed as the Director of Critical Care Medicine, overseeing both the educational and the delivery of critical care at Tampa General, which is a 1,000-bed hospital that's the major teaching affiliate of the University of South Florida College of Medicine. Then I was elected to be the Vice Chief in the Department of Anesthesia, which was, I believe, from 2019 to 2021. And then in 2021, I was elected Chief of Anesthesia, the department, where we currently have 88 anesthesiologists and about 220 certified registered nurse anesthetists. I'm also been the chair of the Critical Care Competency Committee and the Critical Care Steering Committee. I've served as either chair or vice chair for numerous committees at Tampa General, and then also overseen the resident selection process and resident counseling process.
Thank you. Are you published?
Yes, when I was a full-time employee of the University of South Florida, one of the requirements was to publish in the peer-reviewed medical journals. So I've written numerous book chapters covering both anesthesiology and critical care medicine. Additionally, I've had publications that are peer-reviewed, meaning that there's an editorial board that proofreads them for content, make sure they're scientifically valid. And then I've had many more publications in non-peer-reviewed scientific articles to educate fellow doctors in both anesthesia, critical care, and surgery.
Do you know approximately how many articles you have penned?
I would say somewhere on the order of 40 to 50 articles.
Have you lectured?
Yes, I've lectured all throughout the United States, not only in my home state of Florida, but in various regional, state-sponsored and national meetings, again, in both the areas of anesthesiology and critical care medicine.
Are you currently doing any teaching?
Yes, even though I left the full-time employment of the University of South Florida in 2004, I've never left my responsibility to teach the medical students there, the residents, and the fellows. So I've continued throughout that whole time as what's known as clinical faculty, meaning the medical school assigns me residents and fellows to train. I give daily lectures in the intensive care unit. That's usually in the noon hour for those various students. And then I'll also periodically be invited to the university, for example, in the Department of Pharmacology, to lecture on anesthetic drugs for the operating room or the ICU. And then I lecture extensively to the nurses, not only at Tampa General, but to the regional nursing societies on various continuing nursing education topics.
Can you illuminate what kind of advances you feel have been made in your area of specialty as an intensivist over the last 10 to 15 years?
So over the last 2 decades, there have been major advances in the science and the medicine of critical care, both in terms of our ability to diagnose patients' life-threatening problems through new blood tests that we have available, new imaging such as CAT scan and MRI, and then also in terms of processing that information more rapidly so doctors can form a more effective differential diagnosis. Also in terms of new medications that have come to the forefront that we're able to employ, if not to arrest disease totally, but certainly to slow the progression of the disease. Also, we've made major advances in our understanding of both analgesia, which is pain relief for critically ill patients, as well as for the management of sedation in the ICU. When I was a medical student and a resident, it was often felt that patients should be in a state of suspended animation in the ICU, and we realized that that's not the best way to get them better or to promote their recovery from the ICU. So we have much more advanced techniques that can really allow patients, for example, to breathe spontaneously on a mechanical ventilator and be able to separate more rapidly from the ventilator. This, of course, has really become topical the last 2 years with the coronavirus and the pandemic with COVID, since we've had major breakthroughs in our understanding about lung function, how the ventilator either can help or hurt the patients, and then also ways to expedite their recovery, such as things like putting them on oxygen machines that can actually circulate their blood, put oxygen in the blood, and take carbon dioxide out, called ECMO, which 20, 30 years ago was really reserved for newborn babies, and now we found that that's quite helpful in selective patients, managing them as adults in the ICU.
Thank you, doctor. May I approach?
You may.
Dr. Schweiger, I'm handing you a document entitled States Exhibit 32A. Could you please tell me what that is?
Yes, so this is my resume, or what's in medicine we call it curriculum vitae, and it basically lists my education, my training, my work experience, the various committees that I've served at Tampa General and the university, and then the publications, chapters, peer review, non-peer review, and then a lengthy list of all my lectures.
Thank you. Would you just flip through it, make sure that I didn't give you a blank bunch of paper?
Yes, this is accurate as of January 1st, 2022.
Thank you, sir. Your Honor, would the court like me to formally offer him as an expert in this case?
Wrong courtroom.
Okay, thank you. I'll proceed.
We're talking about a custom from courtroom to courtroom. Okay? You can proceed.
Thank you, Your Honor. Dr. Schweiger, could you please describe the hospital service that you offer, starting with your ICU practice?
Yeah, so starting with my intensive care unit practice, Tampa General has approximately 1,000 hospital beds. So it's equivalent to major medical centers such as the Wexner Medical School here at the Ohio State University. They would be similarly structured type of institutions. We have approximately 175 ICU beds. We achieve almost 99 to 100% capacity on any given day, meaning that we usually have some patients waiting in the emergency room or in the recovery room or the operating room to come in. We have to try to discharge patients. So we have a essentially full adult ICU. We have basically 9 various ICUs throughout the hospital. Those include the medical ICU, the surgical ICU, the burn intensive care unit, of which I'm the co-director. We have the trauma ICU, the transplant ICU, the vascular ICU. We then have some outlier ICUs in the new building that we've retrofitted, which can have a combination of medical and surgical patients. And then we also have the Neuroscience Institute that's in the Bayshore Pavilion that has another 32 beds. So in terms of my practice, I usually work 7 days straight in the intensive care unit. So for example, I'll start Monday and I'll go through Sunday. The weekend are 2 16-hour shifts, so I'm just coming off the weekend, this past weekend, when we're in the ICU. We have 3 major ICU services at Tampa General, so anesthesia critical care being one of them. So we would see approximately 1/3 of the patients in the adult ICU. Then there's a surgical trauma team that would see 1/3, and then the medical ICU team would be the 3rd. Again, we routinely don't see patients under the age of 16 except for true emergencies, such as at night if the pediatric people need help with an intubation, putting a breathing tube in, or a line. In terms of the operating room, we have approximately 40 anesthetizing locations. We have 22 operating rooms in the main operating room, 8 on cardiovascular. We have a separate burn ICU. We have 4 operating rooms for gynecology, and then 6 labor and delivery hot places. And then we have a very busy 10-bed gastrointestinal unit where endoscopies are performed. And then there's some other outlying institutions. And again, those are staffed by anesthesiologists and primarily CRNAs.
Do you not only practice but oversee these?
Yes, so as an attending physician, obviously I'm seeing the patient, I'm talking to the family, but one of my responsibilities is also to work in what's known as a care team model. So in the intensive care unit, my primary team has currently 15 advanced practice providers. Those include both physician's assistants and advanced registered nurse practitioners. Then we usually have 2 or 3 residents, and then we have assigned medical students. And we would divvy up the patient list so that each provider would be assigned a certain number of patients, and then the group would see those patients and they would report back to either myself or another attending physician, where we would do multidisciplinary rounds. And those include the attending physician, the resident or medical students, the physician assistant and advanced registered nurse. But we also have things like a dietitian, the pharmacist. It can be also the charge nurse or someone from nursing, so that we can communicate with each other about the patient's status, what the plan is, and how we're moving forward.
Thank you. During the course of your practice at Tampa General, do you have patients who require compassionate or palliative extubation?
Yes, certainly at any ICU that I practice in, there are those patients who, for one reason or another, do not respond to therapeutic interventions, whether that be medical interventions, surgical, or mechanical, such as the breathing tube. So in those patients, we have a palliative care team that we consult with in regard of end of life and what the goals of care are. And then in multidisciplinary discussion, some of those patients will progress to what's known as a terminal extubation, meaning that when we collectively decide to pull the breathing tube out, we will not plan to put it back, even if the patient's condition deteriorates further, because the collective opinion is that the patient is truly progressing towards the end of life.
And is it your testimony at this time that you have engaged in all phases of the decision-making and actually performing the medical services that would be needed to achieve such an extubation?
Yes, as my role not only as an attending in critical care, but also as the director of critical care medicine, I participate in all phases of both the palliative care service, the end-of-life discussions, and, if need be, terminal weans, meaning backing off from the ventilator, up through terminal extubation. In fact, as recently as yesterday, I participated in such a process.
Okay, thank you. Let's turn the page. Do you have a certain percentage of your income that comes from either consulting or being an expert witness in legal matters?
I do. So for the last 2 decades, partly because of my reputation within the medical community and also because of my publication and lectures, I have been asked by various attorneys, both defense and plaintiff, to review civil litigation cases for them. And I have done so over that. And so a percentage of my income, which is approximately 15%, is as a result of my work as a medical legal expert.
Thank you. Describe how this became a part of your life. How did you get involved in it?
So I was first asked to give a statement for an attorney back in the late 90s because I was the treating physician and the attorneys were seeking information about the care of the patient. And then later that year, that attorney called me and said that he liked the way I explained the medicine during my sworn deposition and would I review a case for his firm. I knew very little, if nothing, about forensic work for attorneys, so I turned to my chairman. He set up certain parameters for faculty at the university for participating in medical legal reviews and served in a voluntary role as sort of a mentor to the faculty. And then from there, I began slowly to review cases that were referred by other senior faculty at the university. And then eventually, probably around 2002 to 2003, I was independently contacted by attorneys to review civil litigation, meaning medical malpractice cases.
How often do you review cases involving medico-legal issues?
I would estimate on the order of about 20 cases a year for the last 8 to 10 years.
Do you charge for reviewing one of these cases?
Yes, I do. I have a fee schedule that I charge. I charge $500 an hour for review of medical legal cases, and then for sworn deposition testimony, I charge $550 an hour, and then finally for trial testimony, I charge $600 an hour.
Thank you. Do you advertise yourself?
No, I've never advertised throughout my career. There are organizations that will advertise for doctors. I see no need to do that. Again, I'm not there as an advocate. I'm really serving as a medical expert, so I think that to advertise is really not ethically sound as a physician.
Are you on any special interest panels?
I've served on panels within the institution, both at the medical school and at the hospital
Sir,
to formulate
I think
policy.
you misunderstood. are you on any legal special interest panels?
No,
like
I'm not,
defense
no, I'm
attorneys
sorry.
or- yeah.
No, I've not served on any panels for defense or plaintiff attorneys. I'm sorry, I misunderstood.
That's okay. What percentage of the time do you review for the physician versus the patient?
So in terms of the cases that are sent to me, so when I open a file to review, 40% are on behalf of either the hospital or the physician, and then 60% are on behalf of the plaintiff, the person that is asking for the review of the care was provided.
Thank you. Have you been asked, in the case of the state of Ohio versus William Husel, to review medical records?
I have, yes.
And does this include the medical records of all 14 of the alleged victims in this case?
That is a true statement.
Have you prepared reports in this case?
Yes, after independently reviewing each of the medical records, I did set out to draft a written report on my opinions and facts regarding the review.
Thank you. February 20th. Your Honor, if I may approach.
You may.
I'm handing the witness a document entitled States Exhibit 32B. Dr. Schweiger, could you tell me what this is?
So this was my initial report that I wrote. It was dated February 28th of 2020, and that was my report to the prosecutor's office.
Thank you. Did you also create reports for each of the individual patients in this case?
Yes, approximately a year after preparing the initial report, I was asked to draft individual reports regarding my review of each individual case, and I did do so.
Thank you. I may approach.
You may.
I'm passing the witness a ring binder which contains States Exhibits 32C through P. Sir, could you please tell us what each of those are?
Yes, so this binder includes copies of the individual reports that I authored related to each of the 14 medical records I was asked to review.
Thank you. And is it a fact that those range in size from about 10 or 12 pages to like almost 30 pages?
Correct.
They're various lengths.
That's correct.
Is that correct?
I would say the shortest was about 10 or 11 pages, and the lengthiest one was 28 or 29 pages.
Thank you. Doctor, can we agree that any opinion that you give in this case, you will express to a reasonable degree of medical certainty unless you indicate otherwise?
Yes, I agree to that statement.
Doctor, what does the term standard of care mean in the medical world?
In the medical world, standard of
Okay.
care.
Objection, Your Honor.
Let's sidebar this one.
I'm sorry, Your Honor.
We're going sidebar. David? Time for a law school lecture, okay? The word standard of care comes out of medical negligence cases. That's generally where it's in there. It can be used for other things, but when we talk about violation of a standard of care, that's usually in a negligence case, and that's not part of this case. This case is about proving purpose, okay? Now, I don't know where it's going on this, okay? But just because standard of care is violated, that's insufficient. There has to be other facts or other circumstances to support the purpose, okay? Any objections on the charge?
No, Your Honor, thank you.
Okay. Ms. Grubb?
Thank you, Your Honor. Let's turn to the typical ICU patient.
Well, why don't you finish up what we just explained? You're going to come to that? Okay.
Well, I'd like to come back to it, Your Honor. It seems that perhaps in a later portion of my examination, it would be more appropriate.
Okay.
Let's talk about when you first undertake treatment with a new ICU patient. What does appropriate care require?
So when first consulted to see a patient to determine whether or not they should come to the ICU or if they're already in the ICU, the first step is to obtain a comprehensive history of the patient. Again, many of the critically ill patients won't be able to talk to me as a physician, so I would be dependent upon what's in the medical record already, either from the emergency room or from the transferring institution or physician. We obviously will get history from families or from significant others, any source that we can get information. Next, besides getting the vital signs, we want to do a comprehensive physical examination in order to uncover what organic dysfunction the patient's body is presenting to. We will then order appropriate laboratory and diagnostic studies, so blood work, EKG, chest x-ray, perhaps other imaging, to try to get an idea and try to identify more scientifically what the problem is on the patient. The next step, and perhaps one of the most important early steps, is to form a comprehensive differential diagnosis. By that, what that means is you take the number of diagnoses that you have for the patient and you put the most important one first, the one that really needs to be addressed because it could threaten the life or well-being of the patient. And then you prioritize them from most important to least important, and you create a therapeutic protocol based on that differential diagnosis, which might change while the patient's in the ICU. It's dynamic, but you want to reevaluate that every day. And then perhaps lastly is good communication, not only within your own team and to the nurses, but to the other services that are involved in the care of the patient, so that the various surgical, medical, nursing teams are all on the same program with the patient's care.
How would you characterize the medical condition of the typical ICU patient?
So the typical ICU patient has either one or more organ failures or dysfunction. So for example, if the patient can't breathe and their lungs are sick, that would be called respiratory failure. So in order for a patient to get in the ICU, they usually either have impending failure dysfunction, meaning you know as a doctor it's coming, you can see the way they're deteriorating, and you want to intervene early, or they're already presenting with two or more problems, like they may have liver failure and kidney failure together, and you're getting the patient in the ICU.
Does documentation and protocol matter in dealing with critically ill individuals?
So documentation is essential to the delivery of appropriate care in the ICU. First, the vast majority of the patients in the ICU either can't speak because they have a breathing tube in their throat and in their airway, or they're sedated with medication that makes it impossible for them to communicate. So it's very important to chronicle in the medical record so that each team knows not only the patient's responses, but but also our thoughts. So the medical record, whether it's on paper or electronic, really serves as the fulcrum in which the various healthcare teams communicate with each other. This is especially true in modern medicine when you have more and more subspecialists come into the ICU. So you may have a cardiologist that just focuses on the heart, a diabetic doctor that just focuses on blood sugar. They may not be communicating with each other verbally. They may be communicating with me as the intensivist, but the chart then allows all the doctors to know what's going on and facilitate communication. And then also with each day they're in the unit, because many of these patients are in the ICU weeks or months. You can see with COVID, some are there 4, 5, 6 months. You really need accurate medical documentation. And then equally, you need to follow protocols so that the patient's care can be similar to what other patients with those disease states are undergoing.
Does that allow for the advancement of knowledge?
Correct. Both by documenting appropriately and by having protocols, future generations of doctors, of surgeons, of nurses are going to advance the field. Just in the last 2 years, we've learned a tremendous amount of knowledge about how to manage COVID patients based upon not only good documentation for any one patient, but by pooling that data together, both within hospitals and then across the country to figure what is the best way to treat patients. So without appropriate documentation and without protocols, really then every doctor is just going by what their impression is, and you're not getting a unified approach.
Thank you. In your practice, and as you work with others, is it important for physicians to be accurate in their record keeping?
Yes, well, going back to the last question, one of the goals, obviously, for a critical care doctor is compassionate care of the patient. But we're also there to advance the greater body of knowledge within critical care, within surgery, within anesthesia, so that each generation can advance the delivery of healthcare system. So again, it goes back to by appropriately documenting, by appropriately following protocols, you not only figure out what works, but you also figure out what doesn't work so you don't repeat the same mistakes moving forward. So it also is important because obviously an ICU is 24 hours, 7 days a week. And so you have various shifts of nurses and residents going through there. No one, no matter how dedicated they are, can be there day in, day out, day in, day out. So if you don't have that appropriate communication in the medical record as well as verbally, things are going to get missed within the ICU.
Is there anything appropriately concluded from inadequate medical records?
So often, inadequate medical records speak to a lack of attentiveness of the treating team for the patient, that, again, they're not really focused in on the comprehensive view of the patient. Because, again, if you're spending the time doing the history, doing the physical, looking at the labs, you're going to want to document that and also document your thoughts on what is that differential diagnosis. Now, again, even in a busy ICU, and we have 175 ICU beds, and I may have many, many patients to care for, I still take the time to document, my team documents, so that the people coming behind us know where we're at that given moment and what the trajectory is of the patient's care and also of their prognosis.
Let's turn to the patient and the family. How do you prioritize treatment of the patient while demonstrating care for the family?
So that's a very important aspect of the appropriate delivery of health care in an intensive care unit. As I said, the minute that a patient comes to an ICU, families realize that that patient has usually one or more impending or actual organ failure. So the families themselves have tremendous emotional investment in those patients. These are usually, a patient's mother or father, their spouse, their offspring. They're emotionally tied. Also, as I mentioned earlier, that many times the patients can't verbalize. They may have had a stroke. They may have to have the breathing tube. They could be in shock. So we're eliciting history often from the family. So early on in the ICU, the family is involved. So although our primary focus is always addressed towards excellent patient care and meeting the needs of the patient, we also have to be empathetic to the concerns of the family and make sure that we're including them not only in the daily communication, but also in decision-making, especially if the patient isn't able to participate in the right of self-determination. I mean, if the patient can't say, Dr. Schweiger, I want treatment A or B, then we should try to seek their closest kin, whether that's, a healthcare surrogate or a family member, to guide us and to tell us what that patient would want.
Talk to us about the duty of the physician to the patient as opposed to the family's wishes.
So ultimately, we take a sacred oath as a physician when we graduate medical school, and that's doctor, do no harm. Again, we can't always guarantee to a patient that we can cure their disease. We certainly can do our best to try to reduce their suffering, to try to reduce their anxiety. And so we always try to put the patient and the patient's wishes first. As I mentioned earlier, you want to incorporate what the family has to say, because many times the patient has had conversations with the family explaining what they would want if they were ever faced with life support situations or critical illness. So we will always incorporate their decision, but ultimately we must do what's right for the patient.
Thank you. What markers do you look for to determine the depth of a patient's medical crisis?
So in terms of markers, as medicine has gotten more technologically advanced, and I always remind this of the medical students and the residents, first of all, we should never get away from laying hands on the patient, meaning a careful physical diagnosis, trying to bond to the patient. First of all, that's important for letting the patient know that you care about them. But also, you can get tremendous diagnostic clues about whether a patient is getting better or worse by doing careful physical examination. Second of all, blood tests. We've gotten so sophisticated in terms of our serum or blood markers, we can see trends developing in the intensive care unit. For example, if a patient's blood count is going down every single day they're in the ICU, it's very likely they're internally bleeding, even if we're not seeing it. Similar with heart attacks, we have markers we can look for. Now, other aspects that we look for are the amount of support the patient is needing. So usually when a patient comes to the ICU, they're in shock or they have organ failure. They're going to need many of their organ systems supported. In fact, they may need the ventilator with the breathing tube. They may need what's known as vasopressors, which increase the patient's blood pressure to provide adequate blood flow and oxygen to their brain, to their heart, to their kidney. So if we see a downward trend in those requirements, that they need less oxygen, less ventilator, less vasopressor, that's reassuring. But also I want to mention, often when you have 2 or more organ failures, there may be plateaus. So patients may get better for a couple days, then flatten out, then get better again, where you can come down. So simply the fact that a patient may level off on the vent or vasopressor doesn't mean that they're not going to get better. You have to chronologically and serially follow them moving forward, and then incorporate all that data together to form an appropriate assessment of the patient.
Which markers require patient studies and consultation before a path forward can be seen?
So certainly, starting, 2 of the most important organs are the heart and the lung. So when we look at the heart, we're looking at the patient's primary heart function, how well the heart's beating, and we have monitors that can assess that. Also, as I mentioned earlier, the amount of support they need. There are medications that help squeeze the heart. That's called inotropes. There are other medications.
What's that word?
Oh, inotropes, inotropes. And there are other medications that support the blood pressure by squeezing the blood vessels down and increasing blood pressure. So that would be an important marker. In terms of the ventilator, how much oxygen is the patient on? how does the arterial blood gases look, which are measurements of the patient's blood, looking at the blood chemistry? Can we reduce the amount of support? And then other organs that are important, the kidney, are they making urine? Do they need dialysis? Is their liver functioning? Because every medication we give them has to go through the liver to be metabolized and put out of the body. So those are all major markers that we look for.
Thank you. How meticulous do you consider yourself in terms of study or consultation before you begin making decisions?
So I would say I'm very meticulous. I take my responsibility as a physician in the intensive care unit or in the operating room extremely seriously, that I don't want to make medical decisions or make consultations without accumulating a large body of information and scientific data, because in reality, when you're dealing with critically ill patients, the more information the doctor and the team has, the better the decision you're going to make, and also the better advice you can give to the patient or the family about what their prognosis is. If I see a patient, and I've done critical care for 30 years, but if I see them for 10 or 15 minutes, I can't really give them an accurate assessment about their prognosis. I have to spend the time with them. You know, usually an initial consultation is about 90 minutes, and then the more days and more visits I have with them, the better I can prognosticate what the patient's outcome will be.
Thank you. I don't want to skip into your reports yet, but you use a term in your reports called a patient declaring themselves. What does that mean to you?
So it's a term of art within critical medicine, a patient declaring themselves, meaning that often the patient is the best indicator of their prognosis. You simply have to give the patient enough time to let that patient, man or woman, young or old, show whether their organs can rebound from the injuries and whether they can heal themselves with the help of the doctors, the nurses, the medicines. So often when we have a critically ill patient, particularly if there's something sudden or dramatic, they've had a massive stroke, a massive heart attack, the best way to give the patient, the family, accurate information is to watch them for 72 to 96 hours, 3 to 4 days, and watch how they do through that critical phase. If their organs level off and plateau or even get better, that's going to be a more favorable prognosis. If, on the other hand, they don't do that, then I can, with reasonable assuredness, talk to the family about possibly proceeding through palliative care and withdrawal of support.
Why 72 or 96 hours if the person has suffered an insult like a stroke or a heart attack?
So when patients have major organ dysfunction, particularly the two examples that were mentioned, stroke or heart attack, the body often goes through a process of swelling. Much like if we hurt another part of our body, that you get inflammation and swelling. So it can be very difficult, particularly with the brain, for a doctor to prognosticate whether or not a patient will wake up unless you let the swelling in the brain go away. So usually you need 96 hours to have the amount of edema in the brain reduced to the point where I can really then make an accurate assessment whether the patient will regain consciousness, whether the brain imaging, either by CAT scan or MRI, is truly accurate, and whether there's going to be more bleeding or more problems that we might either have to surgically address or there may be no treatment for. But to rush to a hasty judgment, particularly about brain, heart, and kidney function, can often fool you, because I've had patients who appear to be deep in coma, and then after 96 hours or 5 or 6 days, they slowly wake up and become fully conscious again. So you really need to give that patient enough time to allow their own body to tell the doctors and nurses whether they're recoverable.
Does some metabolic blood work or other lab markers need time to develop also?
Yes. So one of the common diagnoses that critical care doctors give patients in the ICU is known as metabolic toxic encephalopathy. And what that means is that encephalopathy means the brain doesn't work. And toxic metabolic means that there are basically waste products or byproducts in the blood that are basically making the brain not function properly. So we, first of all, need to make measurements in the blood, look at blood chemistries, also look at arterial and venous blood gases to make sure where the patient started and whether or not those are improving before we can say that the brain dysfunction is not related to toxic metabolic encephalopathy. So a classic example is serum lactate. When the body has low blood pressure or low perfusion, the muscle and the gut will often make this toxic compound called lactate. And when that builds up in the body, in you or I, the liver would metabolize it and get rid of it. But if you're in shock, the liver is not functioning normally, so you build up higher and higher amounts of lactate. If that's in the blood, you can't reliably talk about the brain not working. You first have to try to get rid of the lactate to totally say that the brain chemistry is or is not going to be able to recover.
What about appearing to be obtunded or having pupils fixed and dilated? Does that mean that that person is not someone who should receive this ICU trial?
No, not at all. So certainly, if a patient has fixed and dilated pupils, I will admit that's an ominous finding. That's not something we would like to see. But first of all, you have to always understand that in the early phases of resuscitation, shock affects the brain. You know, you may have decreased blood flow, decreased oxygen in the brain. So you could have a patient that initially appears to be either dead or trending towards death, but once they're fully resuscitated, certainly may surprise you as the doctor. So again, it goes back to that process of declaring themselves. You want to first make sure that you've exhausted all avenues of the workup and the diagnosis before concluding simply that the patient's brain or that their neurological status is not salvageable.
What type of ICU did Mount Carmel appear to have from 2013 to 2018?
So Mount Carmel West had what's referred to as an open medical surgical ICU. There are some ICUs in the United States that are what are called closed ICUs. If you get admitted to the ICU, you basically hand over all care to the ICU team. In our institution, the burn ICU is that way. You can't get into the burn ICU unless you're admitted to the burn team. But there are other ICUs in which it's called open, meaning that various consultants, various medical doctors, surgical doctors, even the ICU team are working collaboratively on the patient. And the ICU doctor, rather than being the sole director of the ICU, is really working as a consultant to the admitting doctors. And in reviewing the charts from Mount Carmel West, it appeared that the admitting doctors would consult the critical care team, and they would then provide liaison or consultative services for the patient.
Okay. Why does that matter in this case?
Well, it has tremendous importance because, again, when you're a consultant, the ultimate responsibility for the patient is the admitting physician, the physician who is bringing the patient into the hospital and assuming primary responsibility both for doing what's known as the history and physical, but also the discharge summary. So when you're a consultant, you should always relay your recommendations, both in the electronic medical record, but also verbally, to the primary team. That's particularly important if it's decisions that would impact the life or death of the patient. You wouldn't want to unilaterally, as the consultant, progress to make life or death decisions without including the admitting physician, who may well know the patient much better than the consultant who's just been brought on the case that day or in the last couple of days.
Thank you. Doctor, we've heard during the trial about a lot of treatments and medical terms. I'd like to ask you about a few, just to touch upon them. We certainly know about intubation. That's been the subject matter of the last 5 weeks. But I'd like you to talk a little bit about what the intubation means for the patient, other than just providing a breath of life.
Yes.
What other functions are being provided?
So one of the first lessons that you're taught in anesthesia or in critical care are the ABCs: airway, breathing, circulation. If you can get those right, then 90% of your job is done correctly, and the patient will do well. So obviously, in many critically ill patients, and particularly those who are going to get medication that can alter their sensorium, their airway could be in jeopardy, meaning that they may not be able to maintain a patent airway, and they may have to have an artificial breathing tube placed in. This serves essentially as a connector or tunnel to a ventilator, which can then not only provide oxygen to the patient, but also help blow oxygen mixtures into the lung and facilitate the removal of carbon dioxide. Because the human lungs, in you or I, really has two major purposes: bring oxygen in, but also to get carbon dioxide out. So having the breathing tube will assure of that. Also, patients who are sick, they can't clear their secretions well. They make a lot of mucus. They may have some infection in the lung, which can also add to the mucus. And they may even sometimes have extra fluid, pulmonary edema, or even blood. So by having the tube in, it allows the doctors, the nurses, even the respiratory therapists to suction the airway and clear all that phlegm, mucus out of the body. It also allows critical care doctors to go down the breathing tube with a light wand and look into the lung. So if we can see deposits of pus, we can clear that out. And then we also have various devices we can attach to the breathing tube that are gas monitors. And they not only talk about the function of the lung, but they give us an assessment of how well the heart's pumping. And that's called capnography, which is really just a term of art that describes the measurement of carbon dioxide coming out. But of course, if your heart's not pumping well, you're not going to remove carbon dioxide from the body. And then lastly, it also allows doctors, nurses, and respiratory therapists to deliver medications. For example, patients who have asthma or emphysema may need medication to open their lungs up, what we call bronchodilators, and those are always best administered through the breathing tube.
Why is it important to get rid of CO2?
So the human body is really delicately balanced in terms of the delivery of nutrients into it, but equally important, the removal of waste products. So the major two waste products in the body, one goes out real quickly, one goes out slower. The quicker one is carbon dioxide. When we engage in metabolism, whether it's in the cell of my finger or in the brain, that cell makes carbon dioxide, and the body has to get rid of it because it's basically a poison. It makes the body acidic. And the only way out is really to blow it out through the lung. The acid that floats in our blood has to go out through the kidney. And again, that will take hours or days. So if you have problems with carbon dioxide excretion, the body will quickly become more acidotic, and that not only impacts the lung, but it affects the function of the brain, it affects the function of the heart and the other organs. So you really, from the time we come on this earth to the time we depart, the body tries to keep the amount of CO2 in the blood relatively in a narrow window or band so that the blood chemistries function properly.
Thank you. Let's talk about shock or liver shock. Are those the same thing, or I guess shock liver? Are those related? Are they the same thing? What are they?
Yes, they're related. So the way to look at it, the bigger umbrella is shock, because shock is any time that the delivery of blood, oxygen, and nutrients to various parts of the body doesn't match the needs of the patient. So for example, cardiac shock is the heart has a heart attack, it's not pumping well, it's not pumping blood, oxygen, nutrients to the rest of the body. Now, one of the organs that is among the most important in the human body is the liver. First of all, it gets a lot of the blood flow from the heart. Anywhere from 15 to 25% of each pump will go through the liver. And the reason is because, first of all, the liver absorbs all the nutrients and helps in metabolizing proteins and other substances that the body needs to make. But then the flip side of the liver is it's where a lot of the breakdown occurs. So that lactate I mentioned before, it must be metabolized in the liver. Any medication we take, whether it's Tylenol or an antibiotic, primarily has to be taken to the liver where it goes through a series of metabolic processes. In essence, think of the liver as a factory, or really, some place where things are made or are unmade. So if you go through shock and there is inadequate blood flow and inadequate oxygen to the liver, and the liver shuts down, that often then can put the rest of the body in a state where it's temporarily not working well. And again, much like I mentioned earlier, you have to give the liver at least 3 to 4 days to see whether or not it will rebound, because the human liver is amazing. You can lose 90 to 95% of the functional capability or capacity of the liver, and with support you can bounce back and regain most of that back. But again, you have to give the liver enough time to recover. It won't happen instantaneously.
Thank you. Talk to us about vasopressors. What are they and how do they work?
So vasopressors are a category of medication that doctors use and order for nurses to administer to patients that primarily support a patient's blood pressure. So going back to what I said before about shock and how shock interferes with the delivery of oxygen and nutrients and blood to the body, one of the classic hallmarks of shock is that patients have very low blood flow and very low blood pressure, which we measure. That can be measured on the arm, or it can be measured by putting a catheter inside the artery itself. So vasopressors are either medications that our body itself makes, and then we basically give them pharmacologically, or medications that are similar in effect that help doctors and nurses support cardiovascular function through the phase of shock. And again, we use them even in surgery. If I'm delivering anesthesia for a heart surgery patient, they're going to get vasopressors both during and immediately after the surgery until their heart recovers, and then we can wean them off. So one can't conclude simply that if a patient's on vasopressors that they're going to die, because again, most cardiac surgery patients live. They just have to overcome the initial phase of the stunning of the heart while it's being operated on, and then we can wean them down. But vasopressors are there to support blood pressure, support cardiac function, to provide adequate blood pressure and blood flow to the other organs.
Are there patients where they need multiple vasopressors?
Yes, because the human body itself has various pathways to support blood pressure. We similarly mimic that in the intensive care unit by having various vasopressors that can be used to support the patient. And it's interesting, certain patients will respond better to one than the other, so we may have to switch in midstream when we provide the care. Also, some patients may require 2 or 3 vasopressors, particularly if there is a lot of acid in their body, because vasopressors work indirectly. The way to think about vasopressors simplistically is that they're like the key to your front door. Without the lock, they're worthless. So the vasopressor is injected in the blood, usually on an infusion. We'll then look for the receptor, which is the lock, and then we'll engage there to create the reaction. Acid can alter the function of the lock. So if a patient is very acidic, you may have to first address the acidosis before the vasopressor will work. And that's why many times in shock, you'll see a patient on multiple vasopressors, supporting them enough so that you can get dialysis, you can get the ventilator, all those things to reverse the acidosis.
And are those medications that would be used to support this 72 to 96 hour ICU trial?
Correct. Usually, vasopressors are run to support during that period of the patient revealing their ultimate ability to recover from the disease. They will require one or more of those vasopressors during the period of time while they're getting maximal resuscitation.
Let's talk about pH values. Why does the pH in a person's body matter?
So, again, the human body has been really created and designed with really exquisite architecture. Most of the body's functions require a relatively narrow band of pH to function well. This includes cell membranes, enzymes, proteins that are in the body and in the tissue. So from the time we're born, we usually have a pH just slightly above that of water, so we're just a little more alkaline. So our pH in the blood is usually between 7.35 and 7.45. As we get sicker, we tend to get more acid in the blood, so we become more acidotic. And as I mentioned, it becomes kind of the cat chasing its tail. If you get more acid, the organs are going to function less well, which could make more acid, which could make the organs not function well. So usually you need a period of time of stability, both on the ventilator to blow off carbon dioxide, and perhaps even putting a patient on dialysis or giving them a buffer in their blood to neutralize acid in the blood before you can say that they're not going to recover and that the vasopressors no longer have utility. So again, it usually works hand in hand. We're addressing the pH and the acid-base balance while we're trying to support them with the vasopressors. And then finally, many times, once you normalize their pH, you can then start coming down on the vasopressors.
What kind of a window do you have to correct an individual's pH?
We usually would like to do it within the first 8 to 12 hours, but it may or may not be feasible if the patient has persistent kidney or liver dysfunction, because as I mentioned, the liver and the kidney both work together to help normalize the pH of the blood. So it can be that it might take longer than 12 hours to get that accomplished. So again, we want to try to do it slowly and methodically to achieve the best outcome, not have rapid swings in the patient's pH up or down.
And when does a pH out of the proper range become life-threatening?
So certainly we become exquisitely worried when the pH is less than 7.10. So again, normal is around 7.40. When it falls downward, that actually means there's more acid in the blood. So that's a little bit confusing. Low pH means high acid. So below 7.1, you start to see the organs not working as well. When the pH falls below 6.90, that usually is a very ominous finding. But again, you have to be very cautious because many type 1 diabetics will present with very low pHs, less than 6.9, and if you give them insulin, you bring their sugar down, you give them fluid, they'll fully recover. So not every patient with a severe acidosis is potentially fatal. It really depends on why they develop such a severe acidosis.
Thank you. Talk about lactic acid, and is that related to pH?
Yes, so lactic acid is most definitely related to pH. The body usually uses oxygen as fuel. Much like we put, and for most automobiles, we put gas in the gas tank, assuming it's not an electric car. That's the fuel of the engine. The fuel for the body is oxygen. The reason we need oxygen is so that it can metabolize sugars in the cells. Now, if there's a lack of oxygen, the body does have a backup system. It's called anaerobic, meaning without oxygen, metabolism. It can only do this for a short period of time, and in doing that backup system, the body is forced to make lactate. This is why marathoners start to make lactate as they run further and further into the marathon, because usually beyond 18, 19 miles, you don't have enough oxygen in your muscle, you make lactate. The same is true in critically ill patients. If they have a deficiency in oxygen and they go through this abnormal metabolism, you'll start to see higher levels of lactate, which usually are correlated with a lower pH or acidosis. So that's why frequently we'll use the term a lactic acidosis, meaning the cause of the acidosis is the production of lactate.
What does that mean for the patient's comfort level?
Well, in most cases, it means nothing because unlike the marathoner who makes lactate in the muscles and may have sore muscles, in the critically ill patient, that's not what's happening. They're having a cellular imbalance in oxygen, so you have lactate in the blood. They're not feeling pain from it, and usually the buildup of the lactate is the clog in the system is the liver. The liver is in shock, so it's not able to metabolize the lactate, so it's building up in the blood. But in my experience of now 29 years in the ICU, patients with elevated serum lactates do not experience pain from that.
Can lactate accumulate from surgeries?
Yes, you can have lactate develop. For example, certain surgeries have to be done with a large, heavy tourniquet on the extremity to avoid bleeding. Many times, extensive surgery of the lower extremity, the leg, is done with a big tourniquet. During that surgery, which may be an hour and a half or 2 hours, there may be little or no blood flow other than what gets through the bone to the patient. So you may have high amounts of lactate in that limb, so when you drop the tourniquet, lactate washes out to the rest of the body to be distributed and then ultimately metabolized. Also, if the surgery results in low blood pressure, or if there's hemorrhage and shock, the body will make lactate. So very commonly, a trauma, gunshot wound, a knife wound, you'll see higher levels of lactate because of the loss of blood during the surgery.
Thank you. Is there, let's turn our attention now to cardiopulmonary resuscitation. Could you give us a definition of what CPR is?
Certainly. So when the human heart is functioning normally, it has two components. One is the electrical message that it sends itself. So we're born with an inherent pacemaker towards the top of the heart that tells the heart, you need to beat. And it'll then send it through the wiring that's inside the heart to the muscle, and you'll then get mechanical contraction. So that's the squeeze or pumping of the heart, which sends blood through the rest of the body, and then when the heart releases, it pulls the blood that has no longer has any oxygen back into the right side of the heart to start the process all over again. So CPR first came about in the late 1950s and early 1960s when it was realized that if a patient's heart stops, whether it's electrical or mechanical, so whether it's because they have an arrhythmia or they have a heart attack, that we can externally compress the chest. So if we press on the breastbone, which is directly over the heart, and we pump down vigorously, we can squeeze the heart between the breastbone and the vertebral column, the spine, which essentially pinches the heart and will send the blood that's in it showering to the rest of the body, much like if the heart's pumping itself. Also, when we allow the breastbone to recoil, when the chest goes back up, it creates a vacuum inside the heart that will pull more blood in it. So if you combine high-quality CPR, which is the chest compression, often with artificial ventilation, either mouth-to-mouth or in today's era with COVID and other disease, usually it's with a bag where we're squeezing over the mouth to blow oxygen in, you can generate a percentage of the normal cardiac output. It's never totally normal, it's reduced, but enough to sustain life. And scientific studies have shown, whether CPR is done in the hospital or on the streets of Columbus, that you can usually get, 1 in 5, 1 in 4 patients resuscitated, higher if you have electrical defibrillation that can then allow that patient who might well be salvageable to be transported by EMS to a hospital. And then finally, that, what I just described, is called basic life support, or BLS, basic life support. We can combine it with advanced cardiac life support, which is usually done by paramedics or doctors, where we add the breathing tube, we add injecting medications to start the heart, the electrical defibrillation. So there's basic and advanced cardiac life support.
Thank you.
Hold on for a second. Ms. Crabb, how you guys holding up? It's getting close to break time. You're good? Okay. Keep going.
Thanks. Are there studies about survivability between people that have an arrest outside the hospital versus inside the hospital?
There are, yes. There have been a host of scientific studies, both in the United States, Europe, and Asia, looking at survivability. And what we've discovered through rigorous scientific method is that early bystander CPR, meaning that if someone would fall down in front of me and have a heart attack, if I start CPR early, that increases their chance of surviving, not only to get to the hospital, but to then successfully be discharged. Early defibrillation, getting one of those AEDs at the airport, putting it on the chest, and then it tells you when you need to shock the patient, that will help them survive. So what we have known now by looking at data from all around the United States and Canada, that if you have an out-of-hospital arrest and you get high-quality CPR, early activation of 911, that, again, roughly 20 to 25% of those patients will survive to the hospital and will be able to enter the hospital for potentially cardiac catheterization, possible cardiac surgery, and what have you. Obviously, if you have an event in the hospital, depending on, again, why you needed CPR, the evidence is that it's usually a better outcome. Why? Because someone like me, an intensivist or an ER doc, is right there. We're immediately intervening. We're immediately giving the drugs. Some of these patients are already on the breathing machine, so usually survivability is somewhat better. And then, of course, we have to factor in age plays a role. You're more likely to survive CPR if you're age 40 than if you're age 80, just because as we all age, we do have slightly less capacity for insults to the vital organs.
Does capnography, which you previously discussed, have a relationship to CPR or the effectiveness of CPR?
Yes, absolutely. So what we've realized over the last 30 years is that capnography, measuring the patient who's getting CPR's ability to produce carbon dioxide, is one of the most accurate and least invasive techniques of monitoring the efficiency of the CPR. By that I mean we're not having to stick them with a needle, because you're not going to be able to do that out in the field. You're not going to be able to put a catheter. That's got to happen inside the hospital. But EMS and paramedics have portable capnography that they can put on the end of the breathing tube. So if CPR is effective, capnography is going to show usually a CO2 above 20. So if I were to put a capnography on myself or one of the members in the court, capnography usually ranges between 35 and 45. With CPR, if you get above 20, you're getting good blood flow to the heart, the brain, and the organs. As you go lower, if you start seeing capnography below 5, either the person isn't doing CPR well or there's something else going on. You have to investigate, because those low numbers usually don't prognosticate a good outcome.
Thank you. With CPR, is it possible to fracture a rib?
Absolutely. Remember, I mentioned that CPR must be done vigorously to achieve high-quality chest compressions. I mean, if you were just doing baby CPR on an adult, it's really going to be ineffective because you have to compress the breastbone usually 1.5 to 2 inches down into the chest and let it recoil. So obviously, if you have an older patient, one that may have osteoporosis of their ribs, you could either fracture one or more ribs, or sometimes you'll temporarily separate the breastbone from the cartilage that attaches it to the ribs. Again, that's usually not a fatal event. I mean, as long as you get their heart back and you get blood flow to the brain, we'll accept a few broken ribs. That should heal if the patient survives. We can address that later on. But the key thing is to have high-quality CPR. But yes, we do look for that. The one factor we would certainly want to make sure is if a broken rib were pointed inwards and it punctured a lung, we would have to act immediately because we'd have to re-inflate the lung. Otherwise, the lung would stay deflated.
Thank you. Are there commonly patients in an ICU that have had CPR?
Oh, yes. If, for example, you were to look at an adult ICU, clearly, probably, again, and it varies on any given day, but 8 to 10% of the patients in an adult ICU would have had CPR at some point. Higher in the cardiac unit, probably, less in the medical ICU, but there are a lot of the patients that have had either some short-term CPR or some electrical defibrillation for arrhythmias that is part of the advanced cardiac life support needing resuscitation. So again, simply needing CPR doesn't mean a patient's going to die. Many of those patients will eventually walk out of the hospital.
Jumping ahead a little bit, if you had a patient that you were going to perform a compassionate extubation on, and that person had had CPR, what would you be looking at as far as that CPR to put that as an element into deciding drug dosing?
So in patients who have had one or more rib fractures and have been on life support, obviously one of the aspects that I'm assessing in my physical exam is the patient grimacing? Do they show signs when I take my stethoscope and put it over their rib cage or the heart? Are they indicating to me that they're having pain with just light tactile touch? That would mean usually I would need to give them more because you'll have some patients who don't have a lot of pain. Also, we're looking for paradoxical breathing motion. If the ventilator blows their lungs up, like if I'm puffing in a balloon and you get the balloon up, but part of their ribs goes in, so it's moving in the opposite direction of the lung, those patients are more likely to have pain. That's called the flail, F-L-A-I-L, chest syndrome. If you have ribs, the same or more ribs fractured at two different spots, you can get that abnormal motion. So the other things we look for, has the patient been tearing up? Are they showing signs, even if they can't speak, tears in the eye, hand grips? If they've been turned by the nurses, that's a hallmark of when you can elicit pain from the ribs because the nurses will turn the patient every 2 hours. So if the nurses are communicating to me or the team, every time we turn them, their heart rate goes up, their blood pressure goes up, their face is grimacing, I'll know pretty quickly that the ribs are causing pain. In contrast, if I'm not getting that feedback either on my physical exam, in assessment of the patient, or from the nurses, then likely the ribs aren't a major problem causing the patient discomfort.
Thank you. What is organ failure?
So organ failure is a generic term used by doctors in the ICU, nurses, and other healthcare workers to diagnose when a patient's major organ or organs are not functioning normally. So for example, in COVID, if the lungs shut down that would be respiratory organ failure. The lungs, the respiratory tract are no longer working and need a ventilator. If the kidneys totally shut down and are not making urine, are not putting out the organ toxins that are produced through the kidney, that would be renal or kidney failure. They would need dialysis. So organ failure, whether it's one or multiple organs, is a medical diagnosis when the organ no longer can function appropriately, its physiologic role in the body.
Can people recover from multi-organ failure?
Yes, so certainly patients are more likely to recover from 1 or 2 organ failures than if they had 10, right? Because obviously the more organs that have failed, the sicker the patient they are. But this again goes back to that period of time that you have to be careful. A patient having a transient, which means temporary organ failure, doesn't necessarily mean that an organ will not kick back in. The classic example, again, going back to the kidney, I routinely have patients that have acute kidney failure that make no urine for 18 to 21 days, so 2.5 to 3 weeks, that in the 4th week will start making urine and their kidney function will come back. That's not uncommon. The same thing with liver shock or liver organ failure. We have patients who we have to support for 1, 2, 3 weeks whose liver will come back. So you have to be very careful of a physician to just unilaterally conclude that the organ will never come back. And you have to really, again, look at the blood chemistry, the serum markers that we test in the laboratory, other diagnostic tests within the body, such as imaging, ultrasound, to look at blood flow. If I have a patient who has no blood flow to the liver with ultrasound, well, then more likely than not, it's never going to come back. But if I still have blood flow through the portal vein to the liver, then I'm going to be hopeful that they may get return of function.
What is brain death?
Brain death is a very specific medical diagnosis that critical care doctors, neurologists, emergency room physicians, neurosurgeons will make. It basically means that not only have all the cognitive functions of the human brain, so emotions, thoughts, speech, been lost, but also that kind of the autonomic functions, those in the brainstem that you and I don't need to think about, are also lost. So the brainstem are those parts of the evolutionary brain that go back to reptiles. They tell the heart to beat, they tell the lung to breathe, they tell the stomach to digest food, all the things that we don't have to think about when we're in our sleep. Nobody's thinking about breathing or thinking about the heart functioning. So in order to declare somebody brain dead, we have to go through a methodical assessment, both to assess brainstem function, higher cognitive function, and then, if need be, look at blood flow. Because remember I mentioned with the liver, if the liver has no blood flow, you can safely say it's dead. The same with the brain. If we have a patient that we're not clear about whether or not they're brain dead, then we send them for a nuclear imaging study to look for blood flow to the head. And if there's no blood flow, then we can safely say the patient is definitively brain dead.
What's the difference between brain death and an anoxic brain injury?
There's a very big difference between those two diagnoses. So first of all, let me define the word anoxia, because that's not a common term if you're not in the hospital. Anoxia means the total lack of oxygen. So anytime you hear the word anoxia linked with any other organ, brain, liver, kidney, it means that there was a period in which no oxygen went to that organ. So most commonly, doctors and nurses and healthcare workers use it regarding the brain. So anoxic encephalopathy means that the brain is not working normally, because there was either a brief or prolonged period of lack of oxygen. Again, I would compare this to what I mentioned earlier this afternoon. Toxic metabolic encephalopathy has nothing to do with lack of oxygen. That's poisons in the blood that are interfering with brain function, whereas anoxic encephalopathy mean that the brain is not working normally. Now, again, patients may have a period of anoxia, low or no blood flow with oxygen to the brain, but still have some recovery. This is one of those areas that I mentioned in the introduction about things that we've discovered. We have, over the last 10 years, discovered if we aggressively cool a patient down, so rather than be 98.6 degrees Fahrenheit, we make them 60 degrees Fahrenheit by putting cold blankets over them, sometimes packing the head in ice, putting catheters in the groin that will cool their blood. You reduce the amount of oxygen the brain needs, and you can often help the brain recover during these periods of low oxygen. And that's called targeted hypothermic temperature management, and it's a technique that has been devised in the United States to help with brain injury. So again, the fact you have anoxia doesn't mean your brain dead. You could have anoxia leading to brain death, yes. I mean, certainly if a patient went 30, 60, 90 minutes without oxygen to the brain, more likely than not, you're going to be brain dead, unless you fell into a lake and were basically frozen at the outset. So you have to be very careful to parse those off. Brain death has a very specific diagnostic criteria of which you need to do an apnea test and a brain death exam, and then possibly a blood flow study, whereas anoxic encephalopathy simply is explaining what the root cause was for the brain not working properly.
Let's talk about the hypothermia. Is that is that a technique that would be employed during that 72 to 96 hour period of ICU trial?
Correct. So what we and other doctors throughout the United States have learned is that the sooner you can cool a patient who's had cardiac arrest, particularly if it's an out-of-hospital ventricular fibrillation, the more likely it is that the patient will recover some or most of their brain function. It reduces the amount of oxygen the brain needs to function, but also it reduces the amount of swelling in the brain after you've resuscitated the patient. So usually what critical care doctors have done for the last 10, 12 years is as soon as we either get called to the emergency room or see the patient, we'll start targeted temperature management as soon as possible and then try to achieve low blood temperature, really cooling the patient within the first 6 hours. Again, clearly it's not like a light switch. You don't just immediately cool them. It's a process, but you want to get to the targeted temperature within 6 hours and then try to maintain that for 24 hours. And then after that, we slowly bring them out of that state of hibernation. So then over the next 24 hours, we kind of back them up. So this would occur during that period of 72 to 96 hours in which we're allowing the patient to declare themselves whether the brain and organs will again function. We would be doing targeted temperature management on patients who are suitable for the protocol.
And when was...
Ms. Robb, hold on. It's time for a break, ladies and gentlemen. We're going to give you 15 minutes. Remember the admonition. Mr. Pecos, call us up.
All rise.
Have a wonderful break, guys. Have a seat, Doc. Ms. Grubb, anything for the record?
Not right now, Your Honor.
Y'all can be seated. Ms. Menashe?
No, Your Honor.
Okay. We're on break for 15. moved you up, huh?
A little, yeah. Little promotion.
There's not a lot of luck with that chair.
Thank you. Please be seated.
Okay, Doc, you're still under oath.
Yes, Your Honor.
Okay, have a seat, relax. Ms. Grubb.
Thank you, Your Honor. Dr. Schweiger, ladies and gentlemen of the jury, Your Honor. Just to recap, I think we were discussing some concepts. Dr. Schweiger, can you talk to us a little bit about the effects of paralytics and how they're used in an ICU?
Certainly. So in both anesthesiology and critical care medicine, we use a class of medications known as paralytics. The medical term is neuromuscular blocker. When we administer those, the reason they're called paralytics is it paralyzes the patient's skeletal muscles so they cannot move, and by definition, they cannot breathe. The reason we use paralytics in the operating room are first, in order to put the breathing tube into the patient's mouth. Because, again, even when the patient's asleep, most people don't want us to pry open their mouth, go fishing in the back of their throat. So paralytics provide optimal intubating conditions to put the breathing tube in. Second, for the surgeon, if she or he is working in the abdomen or the pelvis, the muscles are often so tight, it's hard to get to the organs, so you need to paralyze them, the patient, so you can open the belly or the pelvis up to operate. Now, in the intensive care unit, again, we try never to use paralytics other than to intubate, because when a patient is not moving, whether it's because they're in a hospital bed, and most patients in the ICU are obviously not walking around, or if they have paralytics, they will rapidly get muscle atrophy, which will make them weaker and weaker and weaker. In fact, I have a general rule I teach my residents and medical students. For every 1 week in the ICU, it takes 5 weeks to catch up. That's how much wasting you get from being flat on your back. So paralytics in the ICU are occasionally used if, for example, the patient becomes dysynchronous from the ventilator. What that dysynchrony means is if they're trying to breathe in at the same time the ventilator is trying to push out, they're fighting the ventilator. And that can be dangerous to the patient because they can build up pressure in the lung and cause a lung to deflate. So of course, first we will try sedation, and we'll try other techniques to try to synchronize the ventilator. But sometimes, no matter what, you have to use paralytics. Another very important warning or caution is paralytics don't put the brain to sleep. So if you paralyze a patient, they're not moving, but they're underlying awake. And that's, of course, the greatest fear for any anesthesiologist, is to have a patient paralyzed but fully awake during a surgery. So that's why we always couple paralytics or neuromuscular blockers with other anesthetic agents. But also on the other end, if you're giving paralytics, you have to remember that paralytics, for the most part, and there are a few rare exceptions, are metabolized either through the liver or by elements in the blood that will break them down and then put it out through the kidney. So organ failure, whether it's kidney, liver, heart can impact the duration of paralytics. You can take one that might last 45 minutes and make it last 2 hours. So you have to be very careful, because if, for example, you were then trying to assess whether a patient had brain function or could move and they were paralyzed, you would think they're dead because they're not moving, when in fact there's still someone inside. So that's kind of a brief overview of paralytics.
In your practice, if you were going to extubate someone who had had a paralytic within the last hour to 2 hours, what would you do to determine whether or not that paralytic was still active?
So to recap the question, if I were planning to extubate a patient for whatever reason, normally or as part of a terminal extubation, and they've had any amount of paralytics in the ICU, first of all, I would wait. The best elixir of safety is just patience. If you wait 3 hours or more, you will definitely know the paralytic is gone. It's not the paralytic. If you do it early, you can absolutely be fooled. The patient could be paralyzed, and thus, if you extubate, they will 100% die, because there is no way for the human body to breathe if you have paralytics on board. Your skeletal muscles and your diaphragm cannot breathe, even if the brain tells that patient to breathe. If for some reason I had to extubate them, the first thing I would do is I'd bring a monitor in. We use it both in the operating room and the ICU. It's called a twitch monitor. We put 2 probes on the forearm, and we measure the twitches in the thumb, and we shoot 4 electrical stimuli. If I did that to myself, my thumb would go like this, 1, 2, 3, 4. My thumb would basically touch my little finger. It would move that much. If I'm partially paralyzed, I would have 2 twitches, but I'd lose the 3rd and the 4th. If I'm fully paralyzed, when I send the electrical stimulation, there's no twitch. It's 0. We call it 0 out of 4 twitching. So by measuring the twitches, I have an objective test. Whether I do it, my partner, the nurse, a healthcare provider, it's going to be the same twitches. Now, again, you can move it to other parts of the body, but you have an objective test. If there's any doubt, we have reliable reversal medication. We have medication, much like there are medications to reverse opioids. You can give Narcan for opioids. We have had now for more than 60 years medications that reverse paralytics. And again, there's 2 different categories. There's the anticholinesterase category, a drug called neostigmine that we can give, or we have another drug that we can use that's called Sugamadex that actually binds the medicine and pulls it out of the body. But irrespective, not getting too into the pharmacology, if you wanted to pull the breathing tube out to make sure the patient had a chance to breathe, you would wait, you would monitor, and you would reverse the medication. And only then would you pull the tube out. And you have to be particularly cautious if more than 1 paralytic are given, because this is a case where 1 + 1 doesn't equal 2. 1 + 1 can equal 5. If you put 2 paralytics together, it magnifies the depth of the paralytics. And the other little rule is if the patient is getting an infusion, meaning they're chronically getting the paralytic every minute as opposed to a one-time bolus, that's also going to extend the duration. So those are some of the cautions that an ICU doctor or anesthesiologist would use before pulling the tube out in a patient who's had 1 or more paralytics.
Thank you. Let's turn to the elderly, persons over 60 or 65. What particular challenges do they present in determining dosing for the medications that you use in the ICU?
So here again, we've known for 100 years that the elderly, of which I'm rapidly approaching that, so it definitely is of interest to me, is sensitive to the delivery of all types of anesthetic agents, pain-relieving agents, and sedative agents. First of all, the elderly, they just don't need as much medication to have the same effect. So once we get to be 65, 70, we dose reduce the medication. We'll reduce by 20 or 25% the amount of the initial medication we give the patient. Similarly, if we're in the ICU and we're running an infusion of medication, we'll drop the infusion by 20 or 25% so as not to overdose the patient and make them more sedated, more unconscious, more encephalopathic. The next factor that one has to remember is that all human beings after the age of 60, 65 lose some function of their cardiac system. That's why, 65-year-olds don't win Olympic gold medals, right? They're not winning Super Bowl champions because the heart is not as efficient at 65 as it is at 25. So when you give these medications, they can additively drop blood pressure, they can reduce cardiac output, another reason we want to reduce them. And then we also have the issue of the medication going away. So between the age of 60 and 65, for each year of life, the patient loses 1 to 2% of normal function. So if you're going to go from 60 to 90, you're going to lose about 50% of the normal kidney and liver function. Again, that's not disease, that's just age. We have still enough to function. I mean, the patient can live to be 100, but you have to be careful because the dose that I give a 20-year-old that might go away in 30 minutes can often, in the elderly, last 3 or 4 hours. And then the other aspect to remember is that as we age, the functionality of the brain, how quickly it recovers from sedation, analgesia, all types of medication, is slowed. And again, we see this in the ICU. A medication that I might give a younger patient, a pill for sedation, might totally make the 80-year-old unconscious. So you need less medication up front. You need less medication in the elderly as you're giving it. You have to then, on the back end, realize that it's going to take longer for the elderly to clear the medication, and it may magnify the effects of encephalopathy on the brain.
Thank you. Doctor, let's turn to State's Exhibit 32B, which is your first written report prepared and sent February 28th of 2020. Look at this at all. I'm putting up page 4, which is a paragraph regarding what?
So this was a section that I wrote on how the physician, critical care provider, prepares to conduct a terminal extubation and then the concomitant or simultaneous withdrawal of support.
Okay. Your first step is, beyond communication, is the initial multidisciplinary team meeting.
Correct.
What is that?
So obviously, when we're talking about end of life and withdrawal of support, I mean, this is a major decision branch point within the intensive care unit because, again, you want to get buy-in from not only the patient and the family, but also the other healthcare workers that are caring for that patient. So the way we start is by having a multidiscipline, meaning that we have the physicians caring for the patient, the nurses, potentially the pharmacist or respiratory therapist, have the ability to have input into whether or not they feel that this patient has a terminal underlying condition or series of conditions, and whether there's any evidence of reversibility. Because again, a patient may have terminal cancer, but it may be temporarily reversible, and they may have another 6 to 12 months of life. So you want to know, is there ability for that disease process to reverse itself enough that they can have a high quality of life? Now again, the ultimate decision will rest with the attending physician, but we seek the input of the various team members, because particularly for ICU nurses, they function as the eyes and ears of the doctor. They're at the bedside usually, 9, 10, 12 hours, where we're roaming around the ICU. So you want to get as much feedback as possible to make the most educated decision regarding the terminal status, whether care is futile, and reversibility.
Would this be a scheduled event?
Usually it is scheduled as in we would call the team together, particularly if we're going to meet later that day with the patient's family. We would try to have this multidisciplinary team in advance of the meeting with the family.
Would it involve palliative care?
Yes, in almost all cases, whether it's morning, afternoon, or night, we would schedule it so that palliative care could have a representative there and then give their input. Many times they've already had discussions with the patient or their family. They may have access to health care, living wills, health care, power of attorneys, so they can give us additional feedback. But we always attempt to include a member of palliative care in these discussions.
The next section is subsequent meeting with patient and/or family next of kin. What is important about that meeting?
So again, this serves as really the foundation upon which a critical care attending would then proceed with a palliative extubation or removal of life support. And it includes really, as I've listed here, 4 separate factors. And did you want to just leave that up there on the screen? I'm sorry, just because then it disappeared. So obviously, the first is to convey to the patient if they're conscious, but often it's to the next of kin or the family, a realistic appraisal of the patient's physical condition, their diagnoses, and whether or not they're responding to our therapy or if they're likely to respond in a reasonable period of time. So here, I'm not trying to convey that they may have a 1 in a million chance of recovery, but what is realistic if I were to look at 100 or 1,000 patients with similar diseases, is there a reasonable chance that they're going to survive? Second is to obtain the patient if they're able, but more commonly the family's input, because many of them, as I mentioned earlier, have had discussions with their loved one. What would grandma or grandpa want if they were in a hospital? Would they want life support? They've had these discussions over the preceding months or years, and they can then help elucidate the patient's wishes. Number 3 is to establish consensus objectives. Sometimes when we enter palliative care, it's not necessarily to facilitate the patient's death in the intensive care unit. It may well be that the patient wants to be reunited with family in a hospice setting where they can have multiple family members, and they may have days or even weeks of time in the hospice where they still have an adequate quality of life that they can enjoy, knowing that their disease is terminal, but they don't have to die with me and my team in the ICU. They can go into a more pastoral care where they can have adequate visiting hours and just a generally more familiar environment. We've also had some patients who choose to want to die at home. I had one patient who wanted to die with their favorite golden retriever, and we were able to extubate them, make arrangements for them to go home, knowing they were terminal, but in a much more comfortable environment for that patient. And then finally, have a coherent plan. So in my practice and in my team's practice, terminal extubation is never an emergency. It's never a rush. There's never a reason to facilitate rapid removal of breathing tube or allow the patient to die rapidly. Again, they might die rapidly, but that's not the goal. The goal is to have an orderly plan, both to address the patient and their family's concerns, to facilitate adequate pain control if, in fact, there is some element of pain, also to allay their anxiety so that they don't feel air hungry if we bring the tube out, if they need either pastoral care, irrespective of their religious faith, or any other social service to provide that for them as well. So this is really benefited from the multidisciplinary nature by having palliative care who knows what service is available, nurses who have been with the patient, the physicians, if need be even the pharmacologist to participate. And those are, the way to think about it, those are the four walls of the building, right? But you need all four of those, not just one or two. You want to include all of them to have a strong foundation that you can then proceed knowing in a rational manner that you're providing the withdrawal of support and the terminal extubation in a way that would be in the best interest of the patient.
Thank you, doctor. Let's turn to the next page, the preparatory procedures and some of the charting. At the top, there's some discussion about the charting and diagnosis, prognosis. Why is that something that you highlighted?
So as I mentioned, since often there are several medical and surgical teams involved in the patient's care, it is very important to have accurate, legible, and timely documentation of the patient's medical record, particularly in terms of their underlying diagnoses and whether one or more of them are resulting, God bless you, in a terminal state. Also, what therapies have been tried. So, for example, if I am doing a therapy to treat an underlying pneumonia, it would be good that the surgical team knows that so that they know I've exhausted everything before deciding that the pneumonia can't respond to therapy. And also, it provides the benefit as we move forward in the process that, for example, if my shift is over, that the physician who's replacing me knows what the discussion was, what the thought process was, and there's really a continuum of care throughout the whole hospitalization, irrespective of one individual. So that's why the medical record is so important.
Let's drop down to the order set.
Yeah. So the third, which is important, is an organized order set. So over the last 2 decades, as both palliative care has been readily accepted in hospitals and the ICU, there needs to be in the institution protocols that specifically outline how the physician, the nurse, and healthcare team should proceed. Now, that doesn't mean that it doesn't provide tremendous latitude and flexibility for the doctors. There are options within each part of the protocol to provide more or less medicine, provide more or less services. But there should be some stratification moving forward. It shouldn't be that I do one thing and then my partner totally does something else. That just isn't, I think, good medical care, and it provides for a lot of confusion, not only for the nurses and the pharmacists, but more importantly for the patient and their family if they're getting different input and different opinions from the different teams. And then, again, the availability of the treatment team, meaning the IC team and the primary admitting team, coupled with discussions with the palliative care team, and if need be, the ethics team. Again, they're not always involved, but if there is debate, getting ethics involved early so we can lay out the different options for the family, this will provide the most seamless transition into the process.
Doctor, then you go into preparatory procedures, and I believe that there's 3 on page 6, and actually 7 more on page 7. In the interest of time, I don't really want to solicit a discussion of each one of those, but suffice it to say that there are apparently steps that you take leading up to that? Are those listed in this procedure list?
Correct. So without going through each and every one of them, what this list does is kind of line up with what I was just talking about having a protocol so that you can go through, much like when a pilot, when she or he gets ready to lift the plane off on the runway, they have a checklist to make sure we have enough gas, the engines are working, the electricity's on. That's what the critical care team needs to do when they're talking about major life events. And certainly withdrawal of life support, terminal extubation, is a major life event prevent for that patient and for their family. So by having the protocol line up with then those checklist items, again, it helps make the process seamless, and you tend not to miss anything. And also it allows the nurses, the pharmacists, the family to reliably be able to ask questions that the patient is optimized in their condition before you proceed with life support withdrawal.
Doctor, starting at the middle of page 7 of your report, there's a paragraph, palliative extubation and/or withdrawal of support procedure. And then in the middle of that section, there's a discussion of what medications or attention should be given to the person during that procedure. Please talk about the medication protocols listed there.
So many people, when they hear about end of life, focus only on the issue of pain and whether or not the patient is going to get pain relief. Absolutely, that's a role. As an anesthesiologist, I don't want patients to feel pain, and same within the ICU. But as listed here, there are other issues. First of all, many of the patients who are at end of life, if they don't have cancer or bone pain, actually don't experience a lot of pain. This is true, particularly if they have encephalopathy and the brain is not working, or they had spinal cord injury, there may be no pain. So what they really have is tremendous anxiety or fear of the unknown. What happens as I'm dying? What happens after death? So anxiety becomes a major issue. So we spend a lot of time focusing on, does the patient have appropriate orders in place to provide adequate sedation? And of course, that is coupled with monitoring the vital signs, so you have an objective endpoint. And then the other issues, obviously, if you're taking a patient off the ventilator, then the respiratory therapist and nurse are no longer suctioning them. So although you can suction the mouth, many patients at the end of life develop what's known as a death rattle. And what that means is that secretions in the back of the throat, in the upper airway, it gives a rattling noise. That's upsetting to the patient, but more so even for the family, because they feel that the patient may be drowning in their own secretions. So we can alleviate that with certain medicines that are drying agents that dry out the secretions. We can also facilitate better suctioning through the nose and the mouth that makes it much more comfortable for the patient and much more acceptable for the family. And then the fourth is a lot of the patients do have underlying lung diagnoses. They may have emphysema, they may have COPD, they may have been admitted with or acquired a pneumonia, which may make their lungs and airways more irritable. And so in that case, even though you've taken the breathing tube out, they may be more comfortable in the dying process if you give them medication like bronchodilators that help their lungs open up and allow the flow of air and oxygen in easier and the removal of CO2. So again, we focus on all four of them, providing equal attention to all four needs.
Thank you. In the last paragraph, you discuss appropriate dosing.
Yes.
Can you expand upon what you mean by fractionated incremental doses?
So the hallmark for doctors and nurses and pharmacists in an ICU, and I'll expand it even in the hospital, is the concept that once you've given a medication, you can't pull it back. If I've injected it in the patient, it's in, right? So you have to deal with the side effects. So many of the drugs we use are very powerful. We have certainly good benefits, but there are known risks of those medications. So what physicians will do, and order the nurses similarly to follow the orders, is to fractionate the dose, which simply means break it up into smaller pieces or smaller administration. So rather than give 10 of morphine, I might instruct the nurse to give 2 milligrams 5 times every 10 or 15 minutes. So that's the fractionated. And incremental means that I can layer more medicine on. So if the patient has anxiety and their face looks fraught with distress, they're tearing, I might start with a small dose of a sedative, then allow the nurse to double that dose 15 minutes later, and go up on the medication based upon the patient's response, not about my anticipation of what the patient is. The patient may or may not respond. But by observing them carefully and then allowing the nurse to respond appropriately, you have the best of both worlds. You have effective pain relief, you have effective anxiety relief, but you're titrating it to the patient, not the doctor.
Thank you. Doctor, I'm going to hand you two documents, States Exhibit 17A and 17B. What do these appear to be?
So 17A is entitled the unique plan description for terminal ventilator withdrawal, and then it is basically what appears to be an order set that can be utilized when engaging in the withdrawal of life support. And it allows, it has different subsections and has boxes that can be checked depending upon what the physician would order. And then 17B, again, appears to be a modification. So 17A, the date of effect was December 7th, 2010. And then 17B is the effective date, August 17th, 2016. So the 17B is a revision of the former document.
Thank you. Could you please look at the dosing schedules on there?
Okay.
What do you feel about the dosing schedules? Let me withdraw that. Feeling is not appropriate here. What is the accepted medical practice as far as dosing schedules for such a procedure?
So this document here outlines both what are known as intravenous bolus dosing, meaning that a one-time injection to the patient, as well as then follow-up or the incremental fractionated dosing that I mentioned before. And then there's also an option for the patient to have an infusion if in fact necessary. On page 1 of the document, certainly the first option that's provided is morphine, which is actually a very reasonable choice for a patient to receive for terminal extubation because it does not expose the patient to what's known as stiff chest syndrome or wooden chest syndrome. With stronger, more potent narcotics, the patient may rapidly get rigid or develop stiffness in the neck called laryngospasm, which could jeopardize the patient's breathing. So morphine is a very good drug for pain relief, but without that side effect. So the initial doses here seem reasonable. The second backup option here, if one didn't want on this protocol to use morphine, is the drug Dilaudid, which is a semi-synthetic narcotic. It's 10 times more powerful than morphine, but the doses here are appropriate because they're 1/10 essentially the doses for the morphine that are on page 1. So that's still relatively an equally equivalent dose. And then they do provide for sedation the medication known as Versed, and here it lists it as being allowed to be given at 2 milligrams IV push once. And that certainly would be acceptable. That's an acceptable range for an adult. and then there's a follow-up potential for an infusion if the patient has further anxiety. The alternative on page 3, if Versed was not chosen, is essentially a sister drug that's in the same category called Ativan. And here we see that the dosages of the Ativan are much lower because it is of a higher potency. So you would give roughly a half to a fourth of the dose of Ativan that you would give with the Versed. And then at the very end, they have a choice for atropine, which is one of the agents you can use for the drying out of the secretions in the airway.
Thank you. Doctor, could you compare dosing or strength from fentanyl to Dilaudid, hydromorphone, to morphine?
Correct. So let me just make one introductory comment, and that's that as narcotics were synthesized in the laboratory, they became more powerful, which in medical terms we use the term potency. So morphine was one of the first naturally occurring opioids that was discovered. It comes from the opium poppy.
I don't think this is responsive at this point to the question. He said, let me give you an introductory.
Okay, I'm going to disagree. Overruled. Continue on, Doctor.
And then we have Dilaudid, which was then formed as a semi-synthetic, which is similar to morphine, and then we have fentanyl. So to answer directly the question, one also has to understand the units that we're talking about. So 1 milligram of morphine would be the same as 1,000 micrograms. So microgram is 1/1000th of a milligram. So if I look at the potency now, 100 micrograms of fentanyl, which would be 2 milliliters, a little vial, is the equivalent of basically 10 times Dilaudid. So 100 micrograms of fentanyl is equal to 1 milligram of Dilaudid. And then Dilaudid is 10 times more powerful than morphine. So 1 milligram of Dilaudid is equal to 10 milligrams of morphine. So then if we were to look, 1,000 micrograms of fentanyl would be equal to 10 milligrams of Dilaudid, which would mean that it's equal to 100 milligrams of morphine.
Thank you, Doctor. Let's turn back a little bit to the family discussions. What is accepted practice as far as advising the families about the patient's appearance during the dying process?
So when we have the patient-family conference about end of life, that is an opportunity for the doctor who's responsible for the patient ICU to educate the family on what to expect. As I testified to earlier under oath, there is not only fear and anxiety on the patient's behalf, but also on the family about what their loved one is going to experience. So it's very important for the doctor who has supervised these terminal extubations, withdrawal of life support, to give an honest and realistic appraisal about what the terminal extubation will lead to. As I mentioned, the potential of secretions, the evolution of the death rattle, potentially sometimes patients making gasping motion, which can be very unsettling for the families. Explain that we have techniques to minimize that, but they may not appear to be constantly tranquil during that phase. Now again, some patients, as I mentioned, may go through it and survive to go to hospice or go to outside of the unit, maybe even go home. But you have to educate and convey a realistic appraisal of what they're expected, because some families just simply believe that when the tube comes out, that the patient will just lay there and then they'll be within minutes death, and that's usually not what occurs.
Thank you. Is it your opinion that agonal breathing hurts? Is it painful?
No, my opinion is that agonal breathing does not hurt. Agonal breathing is a term of art in critical care, pulmonary and anesthesia, in which patients who have brain injury or lack of blood flow to the brain have essentially a last-ditch effort from the brainstem to tell the body to breathe. So agonal does occur usually in the last minutes of a patient's life, but it is not associated with pain because it's not coming from the top of your head, the brain. It's coming from the brainstem that has no pain receptors. So certainly a patient who has agonal respiration, they might have pain for other reasons. For example, if they had cancer, they might still have cancer pain. So I don't want you to interpret that what I'm saying is that you couldn't have other pain. But specifically to the question, agonal breathing is not painful breathing. There is no pain associated with it.
What about the death rattle? Is that indicative of pain?
The death rattle is disturbing. It is certainly disquieting to the family that sees it, but it's not associated directly with pain of the patient because, again, it's an accumulation of secretions in the back of the throat and in the windpipe. So, again, even if the patient is developing it, my experience has been that those patients are not experiencing pain from the death rattle. It's simply that it may be interfering with their normal respiratory function.
What about involuntary movement of arms and legs of the dying? Does that necessarily indicate pain?
No. So again, whereas certainly if a patient has true pain for whatever reason, they may be moving their arms and their legs. The fact that the dying patient is having involuntary movement of the legs does not transition to mean that those patients are definitely having pain. For example, many of the patients, particularly those that have had brain injury or have had anoxic encephalopathy where the brain is not working, may have a spinal reflex, meaning that if you tickle the sole of their feet, they'll withdraw their leg. But it's not associated with pain. It's just that you've stimulated the motor sensory arc that goes from the spinal cord to the foot and back. So there's an involuntary movement of the leg, but it's not associated with pain or discomfort.
Is it accepted practice to treat the patient exhibiting agonal breathing, the death rattle, or non-painful involuntary movement with pain medication or analgesia to help the family?
No. The goal of providing medication to the sick or dying patient is to treat the patient. So you wouldn't be giving medication to the patient simply to allay the family. Now, as I said, that doesn't mean that we're not trying to make the experience for the patient better. That will translate to the patient's family having a better experience. So again, if they have the death rattle, the way to treat that is to give drying agents and to provide orders for the nurse and respiratory therapist to provide more suctioning. It's not simply to give them medications that would in some way expedite the patient's death. That would be really incongruous with the goal that we're trying to achieve. So again, if you know your endpoint, then you can tailor the appropriate therapy to that endpoint. And of course, you include the patient's family in the discussion. And if they've been educated on the process, more likely than not, they're going to realize that that's part of the last hours or even perhaps minutes of the patient's life.
Is that part of your process, the education piece?
Yes, it's absolutely a fundamental process of terminal extubation and withdrawal support, and the dying process is to provide as much effective communication with the patient's family so they know what to anticipate prior to entering the phase of the withdrawal of support, not after. You don't want to try to play catch-up with them after you pull the tube out. You want to educate them before, and then, of course, continue the communication through the process.
Doctor, do you know of items in the body of medical literature that address acceptable protocol for end-of-life care in the ICU?
I do, yes, ma'am.
Are you aware of Dr. Turog's et al. Article from Critical Care Medicine, 2008, recommendations for end-of-life care in the intensive care unit.
I am familiar with it.
I'm going to present that to you. It states Exhibit 32.
Can you show me?
Sorry. Notes on your list. Which one? Two wrong. T-R-U-O-G. Robert D. Doctor, I'm going to address your attention to page 958. I believe the first page is 953.
Yes, ma'am.
958.
I found the page.
Okay, great. All right. First of all, do you know who Robert Truog is?
Yes, Robert Turag was the head of the consensus statement made by the American College of Critical Care Medicine. So what the major medical organization will do is they'll bring forward a panel of experts, and then they'll have those experts for various topics, pneumonia, shock. In this case, it was end of life. And they will then form recommendations that are promulgated in the medical literature so that all doctors, nurses can see the consensus statement. And Dr. Turag was the lead author on this consensus statement.
Thank you. And is this a redo of one that was issued, an article that was issued in 2001?
That is correct. And that's common, so I just don't want anything that's abnormal. As we get more scientific knowledge and experience, the committees will come back together and often, every 5 to 10 years, reissue a consensus statement that's updated, and that's what was done here.
Thank you. On page 958, is there a discussion of appropriate medication for end-of-life care as someone is weaned from the ventilator?
Yes, the committee put 2 tables in the article. Table 3 is specifically about opioid analgesic agents, and they list morphine, fentanyl, and hydromorphone.
I think it's appropriate to ask how, if at all, he relied upon the article, but as I understand, he was just not reading it.
Doctor, have you relied upon this article in your analysis?
I have, yes, sir.
Okay.
Thank you.
Proceed on.
Thank you. Is there a recommendation in the article for dosing of morphine, fentanyl, and hydromorphone?
Yes, both in the article and then summarized in the table, they have recommended dosages for each of the medications.
Okay. And I see that the fentanyl dosage recommendation is broken down by the actual weight of the person. Is that correct?
Yes, that's correct.
Okay. And they recommend 0.5 to...
Your Honor, leading.
Restructure the question.
What do they recommend as far as the typical adult dose?
So for the medication fentanyl, the committee recommended a dose of 0.5 up to 2 micrograms per kilogram. So again, the average man or woman is usually around 75 kilos. And that would mean, if you went at the upper dose, then you could give anywhere up to 150 micrograms. 2 times 75 would be the maximum dose of fentanyl they recommend for the initial dose.
Okay, and then is there a infusion rate after that?
Yes, there is. So they recommend that an infusion can be provided, and the dose range for fentanyl is between, again, 0.5 micrograms per kilo per hour on the low end, with a maximum infusion rate of 10 micrograms per kilo per hour. So again, they're specifically saying give this dose over 60 minutes, not within one shot.
Let's turn now to the midazolam section on the sedative agents. What is the recommended initial dose for midazolam?
So the committee recommended that the initial dose of midazolam, which also goes by the name Versed, so that's the same drug, is 0.02 up to a maximum of 0.1 milligram per kilo.
And what would that equate to on that 175-pound individual?
Yeah, so for a 75-kilogram patient, the maximum dose, the most that you would give an adult man or woman would be 7.5 milligrams. But again, obviously there's a range here from very low dose up to the higher dose.
What's the low dose dosing?
The low dose is 0.02 milligrams per kilo. So that would be in a 75-kilogram patient, that would mean that you'd be giving only 1.5 milligrams of Versed.
Thank you. Doctor, is it a goal of medicine to ablate or eliminate all pain?
No, in almost all cases, it is either not prudent or not wise to strive to eliminate all pain. The goal is to reduce pain to a range that the patient can tolerate, and then to treat the underlying disease, so by treating the underlying disease to get rid of the pain. But again, one always, as a physician, walks a fine line between giving too little pain medicine or too much. The problem is, if you were to try to eliminate all pain, the danger of those medications would rapidly become apparent. So again, we want to try to do our very best to get rid of as much pain as possible without overstepping the line and really expediting the number of side effects.
Thank you. Do you believe that within your practice and a base of knowledge that all dying is painful?
No, it is within a reasonable degree of medical certainty. It is not my opinion that all dying is painful. Patients that have certainly brain death do not suffer any pain because they can't perceive sensory input. Patients who have had devastating hypoxic or anoxic encephalopathy are unresponsive when I examine them. Patients with traumatic brain injuries, patients who have had massive hemorrhagic shock may have no pain whatsoever. One really needs to examine each patient, each situation on a case-by-case basis, determine whether or not they're susceptible to pain. But I would not agree with the statement that all patients who are dying suffer pain.
Thank you. Is there a reason to believe that every patient will experience some pain or discomfort upon extubation?
No, in fact, the opposite. So if you look at the intubation process, The pain is primarily associated with putting the tube in. You have to use devices to open the mouth, to lift the tongue, to look at the vocal cords. It is a very stimulating, very uncomfortable, and potentially painful process. When we remove a breathing tube, none of that occurs. We suction the patient's mouth in the back of their throat. We deflate the cuff that's at the end of the breathing tube. We gently slide the tube out, and we deposit it in the garbage. There's essentially little or no pain whatsoever. Occasionally, patients may cough when the tube's out. That's often a function of some secretions in and around the vocal cords. But in terms of true somatic pain, like this pain of if I broke my arm, would that be the same? No. I mean, pretty much we remove the breathing tube every day for every patient in the operating room. They don't have pain from that, nor would they be expected to have that in the ICU.
Thank you. If a physician was told that an individual is afraid of smothering during the dying process, would that be a justification for increasing pain dosages or medications?
No. If the patient voiced an opinion to the doctor, the nurse, or the family that they were afraid of suffocation at end of life, the first step is really effective education, communication, that we're not going to let that happen. Secondly is the use of the drying agents to prevent the death rattle, effective secretion control, because again, that's the primary problem that they're having. No one is putting anything over their head. We're not promoting, putting a sheet over their head or anything that would result in a suffocation. Often these patients also have nothing in their mouth. At most, they might have a little nasal trumpet in their tube. And then if those conservative measures, drying, secretion control, suction, doesn't work, then anxiolysis, reducing anxiety, maybe some judicious sedation, would be the primary intervention. It would not be to give them high-dose opioids to suppress respiration. It would be to try to allay the fears of the suffocation, which would come from sedatives.
Would the fact that a family member told a physician, we just want to get it over with, is that a reason to give more pain medicine?
Absolutely.
Or a higher dose?
In my medical professional opinion, within a reasonable degree of medical certainty, it would never be appropriate for a physician to administer large doses of medication simply because a family told me that they just want to get it over with quickly. That's not appropriate. You're not putting the best interests of the patient forward. There has to be, first of all, an investigation as to why they would even voice that. What is the underlying theme that would have resulted in that discussion? And then it goes back to education, that we're going to do everything possible to make them comfortable, to allow the dying process to follow a natural course, to support that patient, but we would not do anything to deliberately expedite the death of the patient.
What if a family member said, I don't want them to feel any pain?
Well, there again, my response to the family member would be, we'll do everything possible to minimize pain development and to treat it appropriately using incremental fractionated dosages as soon as we withdraw the tube and engage in the process. We would not just preemptively deliver large medications because of the potential fear that they may or may not have pain, because again, more likely than not, they may experience no pain. So I wouldn't just deliberately give them a large quantity of opioids just because the family member thought that they might fear pain.
In this setting, that setting being the palliative extubation, how do opioids affect the person?
So opioids have multiple roles when we are dealing with palliative extubation in the patient. Obviously, the most obvious is that opioids are a mainstay of pain control. So you're giving opioids in judicious dosage in response to the patient's response, whether that's by examining them or removing a tube, to ablate their pain. Number two, opioids, particularly the medication morphine, can act as a venodilator. which means that it increases the capacitance of their blood vessels for fluid. So at end of life, particularly if a patient is prone to pulmonary edema, morphine is a very good drug as an adjuvant to prevent the formation of pulmonary edema because it gives them more capacitance in their venous system. In fact, many patients get that in the emergency room if they come in with pulmonary edema. So that would be an added benefit. Also, morphine and Dilaudid, to some extent fentanyl, but not as good, reduces the cough response. So that's why in a lot of cough medicines, they contain opioids because they reduce the cough. So again, if the patient is fearful that they're going to have excessive coughing with secretions, a judicious small dose of opioids is beneficial for that. Most opioids do not have strong sedative properties. In fact, fentanyl has none. So you wouldn't give fentanyl if you're trying to sedate a patient. Morphine has a little bit because it's a naturally occurring agent. So it does have a little bit of sedative property. But the other aspect is that the narcotics penetrate the brainstem, so that base of the brain, and by engaging in the area that controls breathing, it slows the respiratory rate. So that if patients have a disease that results in high respiratory rates, you might give small dose of narcotic to reduce it to normal. But you'd have to be careful. If you overshoot, you're going to cause the respiratory rate to go down, 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 and maybe to go to zero, which of course would then result in a rapid termination of the patient's life.
Talk to us a little bit about the properties of fentanyl.
So fentanyl is unique among the three medications that were recommended in the consensus conference because unlike morphine, which is very water soluble but is not soluble in lipid, which is fats, Dilaudid is somewhat soluble in fats. Fentanyl is very soluble in lipids or fats. Why is that important in the ICU or patients? Well, the brain and the blood-brain barrier is mostly fat. So what determines whether a medication goes rapidly into the brain and binds to receptors in the brain is its ability to go through lipid membranes and then attach to substances. So that's why if you give morphine intravenously, it usually won't start working for about 10 minutes, and then its peak effect will be usually around 20 to 30 minutes. It has a slightly lower onset. When you give fentanyl, because it's so lipid soluble, the arm-brain circulation time is usually 60 seconds, meaning that you start to see fentanyl in the brain as soon as a minute after you give it. And its onset time at the brainstem is usually 2 or 3 minutes. So it's going to have a rapid response. Also, because it gets in the brain and the spinal cord very, very quickly, it's the only one of those three drugs that can cause a very dangerous phenomena called stiff chest syndrome or wooden chest syndrome, which means that you give the drug and it's almost as if the patient can no longer move or breathe. Their chest becomes as hard as this table, and they often develop spasm of the vocal cords. So that occurs from the rapid entry of those that particular medication into the brain. Also, as mentioned, because fentanyl is so much more powerful than morphine, or Dilaudid, it has a much narrower therapeutic window. So going from pain control to cessation of breathing is much more dangerous than if you were to use morphine or even Dilaudid.
Thank you. Doctor, I'm going to offer State's Exhibit 32R. Can you tell me what that is?
Exhibit 32R is a paper entitled Frequent Hypoxemia and Apnea After Sedation with Midazolam and Fentanyl. And this is a paper that was published in the most reputable anesthesiology journal in the world called Anesthesiology. It's a publication peer-reviewed by the American Society of Anesthesia.
What is the thesis of this article?
So, first of all, this is a paper that I'm very familiar with, and I have used as a predicate to formulate my opinions as well as my teaching. And the thesis of this article is to look at the incidence of hypoxia, which is low oxygen, and
I don't
apnea.
mean to interrupt, but I have somebody I got to talk sidebar here. Why don't we take 10 minutes, ladies and gentlemen? We'll go back there. We're going to go till 5 o'clock today, and it's probably a good time to take a quick break. So 10 minutes. All rise. Of course, that's killing our poor guy with the bad leg. I assume you guys will give him sympathy. Remember the admonitions. Steve, relax for a second, Doctor.
Thank you.
Let's talk over here.
Please be seated.
Ladies and gentlemen, thank you for your patience there. Hope you had an enjoyable break. Ms. Grubb, you may continue on. Doctor, you're still on the road.
Yes, Your Honor.
Let me try to orient. Yep, articles. Do you have both of them?
33, I have one.
Okay. You have the,
The frequent hypoxemia article.
okay, got it. Okay. Thank you, Your Honor.
You may want to flush it out a little bit since I interrupted you midstream.
Yeah, I'm trying to get my brain back in the right headspace. Thank you. Ladies and gentlemen, Dr. Schweiger, I believe when we broke, I had handed you an article, Frequent Hypoxia and Apnea After Sedation with Midazolam and Fentanyl. Doctor, are you familiar with this article?
I am, yes.
Have you reviewed this article for this particular case?
I have, yes, ma'am.
Was this article informative with respect to this particular case?
It was, yes.
Thank you. Can you tell us the premise and thesis of this article?
So the premise of this article is to investigate the impact of both Versed, the midazolam, and fentanyl on the patient's breathing ability, specifically whether they develop low oxygen hypoxemia or stop breathing at all. And what the authors found, because what triggered this study was that in the 1980s, there were 80 deaths reported from patients who had gotten midazolam, the Versed, again, in an outpatient arena, like outpatient surgery. So these authors began to investigate, and they noted that at a reasonably low dose, which was 0.05 milligrams per kilo, they found that none of the volunteers who received Versed alone developed either hypoxemia or apnea. If the patient only got fentanyl, half of the 12 volunteers, 6 of the 12, developed hypoxemia and apnea. So definitely...
Doctor, can we stop right there and let's remind the jury of those terms, what they mean?
Sure. So what they found is that in the patients who received fentanyl in the study, half of them, 6 of the 12, had an oxygen saturation that fell below 90%. So most humans breathing room air have a saturation of 98 to 100. 100 is the best that you can have of blood. Less than 90 means you have inadequate amount of oxygen in the blood. And of course, the same data was put forth over the last 2 years with COVID. If your oxygen level falls below 90, go to an emergency room, have someone check on you. So the apnea means that the patient has stopped breathing. There's no spontaneous respiratory efforts. And they found, as mentioned, that half of the patients who received only fentanyl developed hypoxemia and apnea, and they noted that the response to carbon dioxide, which, as we mentioned earlier today, triggers people to breathe. As carbon dioxide goes up in the brain, it tells the brainstem, you need to start breathing. But with fentanyl specifically, it turned that mechanism off in half the patients, that no matter how high the CO2 got, they didn't begin to breathe. But then the major finding of the study, which the authors wanted to bring to all the doctors and nurses, was that when they combined low-dose Versed with the fentanyl, and again, these were in healthy volunteers, that 11 of the 12, essentially 95% of the people, developed hypoxemia, saturation less than 90, and apnea, breaks in the breathing. So it demonstrated scientifically that when you add both of these 2 drugs together, you dramatically increase the danger of the drugs because they're working synergistically, which means, again, not 1 + 1 is 2. When we use the term synergy, it means that 1 + 1 is 5, that it's exponential in response. And they then warned of that those patients should be carefully monitored in terms of their respiratory function for fear that if they receive that combination, albeit in their study at low dose, there could be potential respiratory problems.
Thank you. Could you talk a little bit about the volunteers? What was their demographic?
Yes, so in this particular study, they recruited 12 healthy adult males between the ages of 18 and 40. So these were essentially, college age up through middle age. They had no elderly, and they also said that they allowed no patient to enroll who had any significant medical condition, meaning they took no chronic medications. They had no history of alcohol use or tobacco usage, and they had to have refrained from drinking any caffeine products or taking aspirin for at least 12 hours. So what they were trying to do was basically look at the really healthy group so that one couldn't blame the apnea on either lung disease, heart disease, medications, or something else they were taking. They wanted to see the pure effect of these two drugs together and individually on the brainstem.
Thank you, doctor. Now I'm handing you State's Exhibit 32S, previously offered to the defense. What is that, doctor?
So this is a follow-up study from the similar group at the University of Utah that had done the first study. Dr. Theodore Stanley did a lot of pioneering work in this area. So 3 years later, his group published a paper, same journal, Anesthesiology, the major journal for anesthesiologists, and it was titled Fentanyl -Induced Rigidity and Unconsciousness in Human Volunteers.
Okay, doctor. And did you employ the use of this article in preparation for opining in this case?
Yes, ma'am, I did.
Okay, thank you. Could you please discuss the thesis and findings of this study and the underpinnings, too?
Yes, so the investigators, of course, were aware of and concerned by the danger of fentanyl triggering stiff chest syndrome, which would be that excessive muscular rigidity of the chest and the throat. And they wanted to see in healthy patients, were they susceptible to it like patients in the hospital? So once again, they employed healthy volunteers, similar to in the first group, and they enrolled, again, 12 of these healthy male volunteers. This time, they administered a larger dose of fentanyl to the patients. They administered 15 micrograms per kilo to the patient. So again, in this patient, again, going back to the average woman or average man is approximately 75 kilos, they were giving approximately 1,000 micrograms of fentanyl. And the way they were giving it was an infusion. They were administering 150 micrograms, which is 3 mLs per minute, up till they achieved the full dose, which would take 9 or 10 minutes to get into the patient. And what they noted during this period of time was they drew blood samples so they could measure the arterial blood gases, and also they assessed the patient's vital signs, particularly their heart rate and blood pressure, as well as the patient's response to verbal stimuli and whether they would need rescue with tactile stimulation, like shaking the patient to breathe. And they were surprised because what they noted was that 6 of the 12 healthy volunteers, so 50% of those volunteers, had clinically significant muscle rigidity at that dose. So again, at 1,000 mics or 15 mics per kilo, half the patients became rigid to the point where they were both apneic, they could no longer breathe, and they were unresponsive. So if Stanley told the patient, hey, you take a breath, they were unable to take a breath to verbal commands. And they all had no recall of what had transpired. So afterwards, when they talked to them, none of those patients remembered what had gone on, or of then, the requirements of either tactile stimulation or the rescuers having to breathe for them with a rescue bag, for the period of time until the rigidity resolved. So again, their conclusion highlighted the danger of both high-dose fentanyl to patients. Again, these were healthy patients, let alone ill patients, for the danger of causing rigidity and stiff chest, as well as terminating their breathing in total. And again, these people were not on medications, they had not come out of an ICU, they had no other problems. So you have, again, the potential danger of the worst problems: apnea, lack of responsivity, and the stiff chest syndrome in a relatively healthy population.
Doctor, I believe on the second page of the article, under the paragraph labeled methods, they discuss the demographics of the volunteers. What were those demographics?
Yes, so as said, they again tried to enroll healthy patients, or not, they weren't healthy volunteers. The authors write that they enrolled 12 healthy adult male volunteers. The demographics were first that they were of the age of 23 to 31 years of age. They were all within 15% of their ideal body weight using life insurance tables. So what they wanted to avoid was somebody that was either too skinny or too big that could alter the distribution of fentanyl in their blood. So they wanted to kind of look at a reasonable distribution, because remember we said fentanyl is soluble in fat, so that could have altered it, so they didn't want that. And none of the patients were smokers, because that also can have some impact on the pharmacology, so they excluded that. They had no history of drug use, no history of ethanol, and they were not taking any pain medication, because they didn't want to confuse the data with issues about opioid tolerance or prior exposure.
Thank you. What did they do to assist these individuals after they were deemed to have a problem?
So essentially what they would do then is obviously provide rescue for the patient. And in terms of methodology, as we said, these people were being observed by the examiners for the rigidity. They also had the oxygen monitor on, the heart rate monitor on, the blood pressure, so they could get specific indications. And they were also sampling their blood essentially initially every minute, and then they expanded it out a little bit later to wider intervals. In terms of the rescue, first they attempted to encourage deep breathing by the examiner telling the patient to try to breathe. Obviously, if they were rigid, they could not. So if there was no breathing for 15 continuous seconds, then positive pressure with oxygen was utilized by the researchers to rescue the patient so that they wouldn't go further into their apnea. And they provided oxygen with a bag mask where you squeeze the bag and it blows oxygen into the patient's face via a face mask until the patients later on began to breathe spontaneously on their own.
Thank you. Any further information from that study that you feel is pertinent?
Well, what was important was the lack of responsiveness of the patient to the researchers. So they couldn't tell, these were healthy people, they could not tell the researchers what was going on, that they were essentially frozen, they couldn't move. And also that they had severe apnea, meaning no more breathing. So again, if you're not there to rescue them, that would then rapidly result in the patient having a fatal outcome. And also that, again, there was no recall of any of these patients about the actual events that had occurred.
Thank you. And the dose of fentanyl, again, offered to these volunteers?
So the dose of fentanyl was high because, as we said, they were administering 15 micrograms per kilo. So if we remember back to the consensus recommendation, where you're often talking about 2 mics, this would be, 7 times the initial starting dose. And in these patients, because they were given it on infusion up to that dose, they received 1,000 micrograms of fentanyl, which would be the equivalent of the researchers giving 100 milligrams of morphine, which is a lot of morphine.
Thank you. Doctor, let's turn the page for just a minute to the subject of anticipatory dosing. Does this have an application as indicated in the consensus statement that we just talked about?
So there are instances in medicine in which anticipatory dosing is indicated. For example, if a physician is going to do a procedure on a patient, you know it's going to elicit a certain amount of pain, so you anticipate that by treating them in advance with the appropriate analgesics to minimize or ablate the pain that they may receive. When we're doing terminal extubations, because there's little or no pain associated with that, anticipatory dosing is not recommended. Rather, the incremental fractionated dose, providing a base of the medication, so they have some pain medicine on board, and then titrating it based on the patient's response is what's ultimately the safest and most prudent moving forward.
Thank you. If someone is going to utilize anticipatory dosing in a procedure like a compassionate extubation, what cues from the patient would be appropriate?
So certainly, anyone in the intensive care unit who's dealt with critically ill patients know there are patients who during their entire stay or tenure in the ICU suffer from pain. So patients who have end-stage cancer, they may be repeatedly requiring medication to control their pain during the course, or patients that have multi-system trauma. They have multiple bones broken and they have a head injury. They may have a lot of pain. So you're looking in that situation, if you decide to do anticipatory delivery of pain relief or analgesics before terminal extubation, you want to look for signs, symptoms, or what we refer to as cues that would lead you in to believe they would need that. So first of all, what we would be looking for is there evidence of variability in their vital signs, particularly increases in heart rate, increases in blood pressure, that would infer that they're experiencing pain and going through the fight or flight mechanism. So all humans have in them what's known as the sympathetic nervous system, that if something dangerous comes at us, adrenaline is released, heart rate goes up, blood pressure. Certainly pain will do that as well. So if we see that, that's one cue that we're looking for. Number two, facial grimacing. If patients look uncomfortable, if they're grimacing in the hours and days leading up to the terminal extubation, if they have tears in their eyes, those are cues that we incorporate into the decision whether or not that they have subjective pain that needs to be ablated. Third is there continual or intermittent changes in the patient's consciousness or brain function? So for example, as we said earlier, if the patient is brain dead, there's no indication for anticipatory analgesic delivery because they're not getting blood flow or sensation to the head. They can't be experiencing. However, if patients have waxing and waning mental status, and during the times they're awake, they appear to be uncomfortable, then certainly we would do that. Also, if the patient has consciousness even if it's intermittent and there's irregular flailing movements of the arms or the legs, particularly if those arms or legs have injury to them or have had surgical procedures, that may lead me or my team to provide some anticipatory analgesia for the patient. But again, we come back to, you're looking for both objective cues, vital signs, as well as subjective findings on the physical exam and or those reported by the nursing staff to indicate that the patient would benefit from anticipatory analgesic delivery.
Dr. Schweiger, in your practice, do you see pain scoring where it's a solid 0 for every 2 hours, and then all of a sudden, prior to extubation, a high pain score would be entered?
No, in the 3 decades that I've worked in the ICU as both an attending and a fellow, I have not seen continuous pain scores of 0, 0, 0, meaning no pain, and then right prior to proceeding to a terminal extubation, that the pain score would go to an 8 out of an 8, or if there's some other visual analog scale that was used. That would just be both illogical, because there would be no reason why right before terminal extubation the pain score would rapidly rise without anything else changing for the patient. And it would be incongruous because, again, by the time we get to the decision about terminal extubation and withdrawal support, we've done repeated assessments of that patient's neurological status. So if we haven't found that they're interacting with us and reporting pain or showing cues if they're unconscious, it would seem very implausible that at just the moments before terminal extubation, they would have a maximum pain score.
Thank you. Are there more than one type of palliative extubation?
So,
Or method, I guess, would be the proper term.
yes, there are, at times, a gradual weaning of the amount of ventilatory support over several hours is preferable rather than just a sudden extubation. First of all, this allows you to assess how well the patient is going to tolerate having the tube taken out, because you're gradually weaning the amount of support, both in terms of how many breaths from the ventilator, but also how much oxygen the patient needs. So if you do that over 2 or 3 hours, it gives you a pretty predictable assessment of where the patient sits at the time you're proceeding with withdrawal of support. Now, again, there may be other issues, for example, about organ donation or other reasons why we might alter the decision or timing. The family or patient may have wanted organ donation. But that is kind of the gradual process versus the more sudden, abrupt termination where you simply turn off the ventilator, pull the breathing tube out, provide whatever protocol of medications you use to the patient.
Thank you. When you prepare to extubate someone palliatively, what care or regard do you pay to dosing, and how do you decide the dose?
So, of course, dosing should always be titrated to the patient, both in terms of what have they needed leading up to the decision to provide these medications at the time of the terminal extubation. What is their age? Because as we said, the elderly have a reduced dose requirement. What's their organ function? Because again, if they have kidney, liver failure, they may not be able to metabolize the medication. Also, a question that we ask is the patient opioid naive or benzodiazepine naive? Meaning, have they ever been on those medications before? Many of the cancer patients may have been on narcotics for months or a year leading up to the terminal extubation. So those patients may require more. But the average patient who comes into an ICU who has not been suffering from cancer routinely has only had sporadic administration of opioids and benzodiazepines, and often with breaks in between, or has not received them at all. So in that case, in the latter group, they would require lower doses. So our goal is always to provide an adequate initial dose to cover any potential discomfort, but without interfering with underlying organ function, particularly brainstem, respiration, and heart, which would lead to the sudden death of the patient. Again, the goal is to provide them pain relief, anxiety relief, but then allow the natural dying process to continue and not accelerate it.
Is it accepted practice to use a benzodiazepine on a patient not suffering from anxiety?
No, within a reasonable degree of medical certainty, there would not be an indication to provide a benzodiazepine, of which Versed and Ativan would be two classic examples, because the reason you're giving a benzodiazepine is to reduce anxiety, to provide some element of sedation, essentially to be an anxiolytic, which means to calm a patient down. If the patient's not interactive with the environment, brain injury, hypoxia, or not showing any signs of anxiety or agitation or fear, then there's no indication to give it. And of course, there's tremendous danger because of what I discussed in the Stanley article. 11 of 12 patients that got both medications developed apnea and hypoxia. So you want to only give medications when they're needed and then titrate it appropriate to the patient's response.
Is there a simple way for the average person to understand what 1,000 micrograms of fentanyl would compare to in, say, the usual home dosing? If we, say, for example, had a prescription from a doctor for 10 milligrams of morphine taken as needed, what would the equivalent in morphine be in that prescription bottle?
Objection, Your Honor.
Sustained, asked and answered. You had to go through the analysis of the ratios.
Okay. What factors are considered when selecting an initial dose for the extubation?
Objection, asked and answered.
Do you consider?
Finish your question.
I do.
Okay, well, that's sustained. You
Okay.
went over that earlier.
All right. Is obesity a concern when selecting a dose of an opioid in this setting?
Yes, so obesity has to be factored into the assessment of the critical care doctor. First of all, obesity can impact the upper airway. We know that patients who have obesity are much more likely to develop obstructive sleep apnea, and thus if you pull the breathing tube out, they may collapse their upper airway. Apart from the fentanyl issue, as a laryngospasm, it could just be upper airway obstruction. So you have to be cautious about obese patients when you're giving them narcotic. Secondly, obese patients are more likely to have a phenomenon known as central apnea in the brainstem itself, where if you give them even normal doses of opioids, they can become somnolent, which means sleepy. And as they become sleepy, they breathe less, and so they develop what's known as carbon dioxide or CO2 narcosis. So whenever you hear a doctor or nurse use the word narcosis, it means sleep or sleep-inducing. When you get a patient that is obese who then gets narcotic, the buildup of carbon dioxide will then trigger more sleep and a deeper level of coma. So you have to be very careful. That really raises a major danger if you have a patient who has obesity and they have underlying lung issues and you're now giving them narcotics. They are much more susceptible to the impact of respiratory depression. Also, as I mentioned, they're less susceptible to the life-saving benefit of CO2 triggering the brainstem, essentially the fire alarm in the brain that say, hey, you need to breathe. And then lastly, obesity reduces hepatic blood flow. So you get less blood flow both through the hepatic artery and the portal vein, so the metabolism of drugs in the liver is dramatically reduced, and also particularly for medications that are lipid soluble, they have a bigger reservoir, bigger volume of distribution.
So to place that into terms that we lay people can understand, does that mean that an obese person should be considered for less narcotics or more?
Yes, so in lay terms, because obese people are more at risk from the side effects, you should always reduce the narcotics when you have someone who's overweight. And that may be even to reduce it by as much as 50%. Again, to get them into the safe zone so they don't have all those bad dangers that I mentioned in the prior response occur.
Would they then be in the same category as the elderly?
Yes, from a physiologic perspective, meaning how the drug acts within their body, the elderly and the obese have very similar phenomena. Remember I mentioned as we get older, the amount of liver and kidney blood flow go down. Well, that happens in obesity. In terms of apnea, particularly in men, you're much more likely to get apnea obstructive if you're a man and you're over 50 than if you're younger. So again, both of those demographic issues have frequent similarities and would indicate a dose reduction and certainly never a dose escalation.
Does the use of vasopressors inform this decision?
Well, certainly patients who are on vasopressors who have lower blood pressure in general should receive less in the way of opioids because the opioids could further reduce the cardiac output, further reduce the blood pressure, and affect the venous return to the heart. So if you have a patient who was dependent on 1, 2, 3, or more vasopressors, and now you are going to start giving narcotics, that would be a concern. Also, similar to age and obesity, vasopressors may reduce the blood flow to the liver, so you'd have to be cautious, again, in giving large doses of opioids to patients who have been on vasopressors because they likely would not metabolize them the way they would had they not been on those drugs.
What about the status of the patient as far as being conscious or unconscious? Does that inform this decision?
Well, certainly, if a patient is conscious, they're more likely to be able to interact with the physician, the nurses, the healthcare workers, and indicate whether they're having pain, anxiety, fear. So you would factor that into your calculation. If the patient were unconscious, then you would have to use those nonverbal or non-conscious cues. Is there grimacing? Is there tearing? Is there abnormal limb movements? Are the vital signs going up and down? So again, in unconscious or non-responsive patients, prudence would dictate that you would use less until you saw specific clues or signs that the patient needed more once you did the terminal extubation.
What about opioid tolerance? Does that inform this decision?
So opioid tolerance may or may not impact the decision. The fact that a patient has received opioids in the weeks or months leading up to it, of course, again, doesn't necessarily mean that they're still tolerant of opioids at the time they're in the ICU. Again, you have to assess that. What we would be looking for as ICU physicians and the ICU staff, are they having breakthrough pain on standard doses that we're administering? Are they then showing us a lot of those signs that would indicate they are tolerant? Certainly, if there is defined and documented tolerance, then it's more likely they could tolerate a higher dose. But absent a true documented history of opioid tolerance, and or the clinical effects that we see in the unit, that they have required dose escalation, that they've had breakthrough pain, that they've had visual clues or cues, then no, they wouldn't necessarily just routinely require higher doses at time of terminal extubation.
What about home medications?
So home medications certainly should always be factored into our analysis. Again, we want to determine, have the patient been on opioids at home? Have they been on other pain medications? Have they previously been prescribed or taking benzodiazepines? So yes, I do factor that in. But the fact that perhaps a patient had a broken hip and was on some Percocet 6 months ago does not translate that now, 6 months later, when they're in the ICU, that they would necessarily be opioid tolerant. So the key theme in all these patients is that home medications should be factored in on a case-by-case basis with, again, daily and appropriate assessment of the patient's response, and also including feedback from the nurses and the pharmacy staff, who also have their ability to assess whether or not the patient's home meds are impacting the requirements moving forward.
Does the current hospital dosing, which appears to be controlling pain, inform this decision?
Yes, absolutely. That is certainly one of the major indicators we use in the ICU as to the ultimate amount of pain relief or analgesia at the time of terminal extubation or withdrawal of support is what they needed in the preceding day or week leading up to that. If the patient has achieved effective pain control on steady orders or steady state infusions of narcotics, then in my clinical experience, there's very little indication that you would need an exponential increase at the time of terminal extubation and weaning. Rather, you would continue that amount of pain medicine with clear and active orders for the nurse to give more if it's indicated. So if we see any signs of pain, whether it's 15 minutes later or an hour later, obviously they can have more. But if you've already achieved adequate pain relief and extubation itself is not painful, there's usually little indication for a rapid dose escalation from that baseline state.
In your practice, have you seen situations where, strike that. Doctor, what is the difference between sedation and pain control?
So sedatives and sedative hypnotics rarely provide pain relief. In fact, many of the common drugs we use in the operating room, like propofol, that white creamy material, provide no pain relief whatsoever. So sedation, what that means is that it reduces the firing of the brain and brain cells to the point where it either slows cognitive function or can dramatically reduce the ability to process message in the brain. That, of course, reduces anxiety. It reduces memory, so there can be amnesia as a result of it, and generally, in layman's terms, calms the patient down. Now, again, they may still experience pain, but they may not remember the pain if they have amnesia. Analgesics, on the other hand, are primarily focused on providing the patient pain control, either in the brain or in the spinal cord area itself, but are not primarily aimed at sedating the patient, having them get sleepier, making them lose consciousness. Those could be side effects, but that's not really the goal. Again, the one exception might be morphine, which does have some naturally occurring sedative properties. But for the most part, when we try to separate those two out, and when we are delivering a protocol to provide sedation, we rely on sedative hypnotics. And when we rely on pain control, we go to the opioids and those category of medications.
Thank you. Doctor, what experience do you personally have with using fentanyl?
So in my medical practice, I've used it in tens of thousands of patients. Certainly, almost every patient who comes to the operating room for an anesthetic, unless they're allergic to fentanyl, will receive fentanyl. And the starting dose in my practice is 50 to 100 micrograms of fentanyl for a major operation. And then, depending how they react to the surgery, they may get some more, with usually the max amount for surgery being 250 micrograms. In the intensive care unit, again, we favor morphine first because if you go to fentanyl right away, the more powerful the narcotic, the more likely they are to develop tolerance to the drug. So in my clinical practice, yes, I do use fentanyl in the ICU, but usually I use a stepladder approach. I would start with morphine, try to optimize that. If that's not working, then go to Dilaudid. Also use some non-narcotic analgesics like non-steroidals. And then, obviously, if they're having breakthrough pain, add the fentanyl later. But I have certainly vast experience with using fentanyl.
And when you say major surgery, what kind of surgeries do you attend?
So by major surgery, I'm talking about surgery in which the surgeon will enter the abdomen, so exploratory lateral.
Objection relevance?
I'm going to permit it because it talks about its usage, so
Thank
go
you.
ahead.
Thank you.
So entering the abdomen and their pelvis, major orthopedic surgeries such as joint replacements, hip and ankle, or hip and knee, orthopedic trauma, bone fractures, breaking the big bone in the thigh, the femur. For cardiac surgery, we would start with that, and then we would titrate depending on. So these are, we're not talking about superficial surgeries where, someone's removing a skin growth. We're talking about entering the body cavities or working on the major joints.
And you indicated your top would be 250 micrograms?
Yes, assuming that the patient did not have any prior opioid tolerance, most patients have adequate analgesia with 50 to 100 micrograms up front at the start of the anesthetic, and then titrating additional up to about 250 micrograms for the surgery.
Thank you. Do you use fentanyl in palliative extubations?
Not as a primary agent. My personal preference in my practice is to use morphine. Again, morphine, it's a weaker drug, so it's more easily titratable. It provides inherently some sedation to the patient, which is beneficial. It also has the benefit of reducing, I think, more effectively the cough reflex, and thus is an adjuvant to try to minimize the death rattle. And it has a longer half-life. So again, whereas fentanyl, its effect usually clinically is gone in 1 hour, and you'd have to give more or put them on an infusion. Morphine routinely in the terminal phase lasts 3 to 4 hours. So it gives them less peaks and valleys and a smoother course. So I tend to favor that. Have I used fentanyl? Yes, usually in patients that have had severe terminal cancer who have required high amounts of narcotics through their cancer treatment and into the ICU, and that they've already been on fentanyl, particularly on an infusion. Then in those situations, I'll usually order that the fentanyl be continued.
Thank you. Your Honor, I'm about to go to a transition. I just want to consult for just a second, if I
Okay.
could. Your Honor, I'm going to transition to our first count involving Joanne Belisari.
I imagine it's going to be more than 8 minutes.
I believe so, Your Honor.
Okay, let's go home, guys. Remember the admonition? We'll get started at 9 o'clock in the morning. Okay, I'm 9. I'm going to rob about half an hour of the hour and a half lunch from you. We'll probably do 2 breaks in the afternoon like we did today. Okay? And the breaks are not only for you, Sam too. Okay? No 8:30. And the lawyer's not going to have a talk about that, but tomorrow morning, no 8:30. Okay? David?
All rise.
Have a wonderful evening, guys.